Well, 'cause you make my dreams come true. Oh, yeah. Wow, 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 you make my dreams come true. Oh, yeah. Well, listen to this. I'm down on my daydream. Oh, that sleepwalk should be over by now. I know. Yeah, yeah. You make my dreams come true. Oh, yeah. I'm waiting for you, girl. Oh, yeah. You make my dreams come true. Me, you, me. I'm waiting for you, girl. Oh, life. You make my dreams come true.
Good morning, everyone, and welcome to the annual Services for Teens at Risk Center Suicide Prevention Conference. My name is Tina Goldstein, and I have the great honor of leading the STAR Center. We're grateful to have you join us for a day of learning with an incredible lineup of presenters today. The theme of this year's conference is Artificial Intelligence and Human Connection, reflecting both the exciting possibilities and the enduring foundations in suicide prevention research and practice. In our first keynote, Dr. Matt Nock will share how advances in technology are transforming how we identify individuals at risk and expand access to timely support. And as we all know so well, no technology can replace the impact of a caring adult, a supportive peer, or a genuine connection to the community. In our second keynote, Dr. David Schonfeld will discuss the effects of trauma and loss on children and guide us through crisis response involving universal support. Our afternoon breakout sessions will highlight evidence-based approaches to engagement, assessment, and intervention with a focus on both risk and resilience. Before we begin, I'd like to acknowledge funding for the STAR Center by an appropriation from the Pennsylvania General Assembly. I also want to thank Jamie Sebi, our STAR Outreach Coordinator, for her tireless work coordinating today's conference, as well as James Ferris and his team for all their support with our technology today. Additionally, I want to recognize all of the members of the dedicated team at the STAR and CoSTAR clinics, STAR Outreach, and our research teams who carry out the STAR mission every day. Thank you all for being here and for the work that you do every day on behalf of youth and families. I hope today's conference provides you with valuable knowledge, meaningful discussion, and practical tools that you can bring back to your schools, your clinics, organizations, and communities. And now I wish to invite the founder and co-director of the STAR Center, Dr. David Brent, to introduce our first keynote speaker.
Good morning. Thank you so much, Tina. My name is David Brent, and I have the privilege of introducing Dr. Matt Nock, who's a professor of psychology at Harvard University. And I would simply say he's the single most creative researcher in suicide research today, and an inspiration for me. Today, he's going to speak about some of the innovations that he and his team have been working on to improve our abilities to predict and prevent suicide. And I think what you'll find is a lot of, despite the glitter of technology, that it really comes from basic human connection, just with some technological underpinnings. So at this point, I'd like to turn the conference over to Dr. Nock, and I think you'll all agree with me that you're going to learn some amazing things. Thank you.
Thank you so much, David, for that generous introduction. Thanks to David and Tina in the Star Center for having me here, and thanks to you all for joining. I have to say, Dr. Brent has been my personal research and clinical hero since I entered the field about 30 years ago. So it's a real honor to be here. And as a general rule, anything that David, Tina, and the Star Center asked me to do, I say yes to, because they are leading not only the country but the world in this suicide prevention work. So thank you so much for having me. A huge honor to be here. With the time that I have, I want to share some research that we've been doing aimed at trying to, as David mentioned, use new technology to improve our ability to understand, predict, and prevent suicidal behavior. As David also alluded to, I am going to talk a lot about technology, but I want to highlight that we're trying to approach this problem through a very human lens. I'm a clinical psychologist by training, trained behaviorally. I'm a licensed clinician as well, and our North Star here is really to try and understand, predict, and prevent suicide. Technology we see as a tool to help us better do this, but prevention is really the driving force. In terms of disclosures, we are fortunate to receive funding from NIH, National Institute of Health, Department of Defense, and several private and family foundations. I received some book royalties, and I have some relationships, mostly consulting with some companies, these largely aimed at doing a similar kind of work. None of these I perceive as a conflict of interest. I'm not talking about any products that I benefit from in any way, but want to note these disclosures before I start. I would also start by saying the obvious, probably to this group, that this is a really complex problem that we're trying to understand. Suicide has been around since the beginning of recorded history. It's something that humans have struggled with and puzzled over for literally thousands of years. And for a long time, the question of suicide fell in the domain of philosophical inquiry, and virtually every major philosopher over the years has written about the question of suicide, to be or not to be, and so on. It's only the past 100 or so years that the problem of suicide has fallen into the lens of health professionals. It's still a huge, huge problem, and there are more suicides each year in the US and around the world than all violence combined. So, all wars, all genocide, all interpersonal violence, which means although we all worry a lot about violence and wars, and this is a lot of what fills the newspaper and so on, we're each more likely to die by our own hands than we are by someone else's. And that's true not just of those of us who are adults, but sadly, it's true of young people as well. Suicide tends to hover around the 10th leading cause of death in the US, but the second leading cause of death behind only accidents among young people, ages 10 to 34 years. For those of us who are parents or work with younger people, this is a really highlights how important of an issue this is. And sadly, although over the past 100 years we've seen mortality rates drop precipitously for most leading causes of death, cancer, pneumonia, motor vehicle accidents, HIV/AIDS, most recently COVID, a problem is identified, medical science directs its lens at it, we make progress, this is translated into better care, we see mortality rates drop. This isn't the case with suicide. This is a very recent paper, or findings from a very recent paper that was in the journal Proceedings of the National Academy of Science. And what I want to highlight here is you'll see that the bigger square here shows the suicide rate from 1900 to 2020. And you'll see it bounces up and down, but it effectively hasn't changed over the past 100 years. We see the rate of about 14 people per 100,000 die by suicide each year, and that hasn't changed over the past 100 years. If I showed a figure with other leading causes of death, you'll see that they're all lines going straight down. And we see this broken out on the right here. Mortality rates due to heart attack, homicide, motor vehicle accidents has decreased. Overdose deaths, suicide deaths has skyrocketed over the past 20, 50 years. So this is still a very, very big problem for us to try and get a better handle on. It's not all gloom and doom. We've made some advances over the past few decades. A lot of the advances we've made have been through large-scale epidemiological studies. This is a figure from using data from the World Health Organization World Mental Health Survey, which the line here shows what's the risk of increase in suicidal thoughts. Each line's a different country. There's 17 different countries here based on year of life. What I want to note here is there's very little suicidal thinking in children, but in every country you look at, when you hit adolescence, the risk of suicidal thinking skyrockets. Clear finding over the past few decades. We've also learned, using large-scale epidemiological data, the probability of transitioning from suicidal thoughts to attempts is about 1/3. So about a third of people who have thoughts of suicide will ever make a suicide attempt. That's true in every country we examine. And the risk of making an attempt is highest the first year after onset of suicidal thinking. What this second figure shows is what's the probability of transitioning from thought to behavior among those who do by year after onset of suicidal thinking. And in every country we examine, 60% of the time or more, if a person's going to make a suicide attempt, they do so the first year after the onset of suicidal thoughts. Again, making suicide among adolescents a really big issue, and the first year, usually in adolescence, after a person starts thinking about suicide, should be the time we're really scanning for risk of suicidal behavior. We've also learned through decades of research that half the people who die by suicide saw a clinician of some kind in the 30 days before their death. Often, this isn't due to complaints about suicidal thoughts or suicide risk. In fact, only in about 15% of these cases do we see documentation in the medical record of suicide risk. Often, this is people coming into the primary care clinic, school psychologist, social worker, licensed mental health practitioner saying, I'm feeling down, I'm feeling depressed, I'm not sleeping well. but folks are getting themselves in front of clinicians. We're just not doing a good enough job as researchers at pointing toward how to identify folks most at risk. And I'll also note we've learned the few weeks after someone leaves a psychiatric hospitalization is an especially high risk time for suicide risk. So we've made big advances in our understanding of suicide largely through epidemiological studies. Not to say we haven't made advances through brain imaging and pharmacological studies and so on, but some of the big universal findings we're having are from epidemiological studies. What I'm going to talk about today is the fact that the nature of suicidal thoughts and behaviors have made them really difficult to study. So these findings that I've described so far are sort of broad picture, 30,000 feet, who's at risk for suicide. But predicting, for those of in this meeting who are clinicians, who are teachers, who are family members, it's really hard to identify which person at which point in time is going to be at highest risk. And there's no perfect metaphor here, but I think a lot about this work as akin to trying to predict extreme weather events, tornadoes, hurricanes, and so on. Similar to suicide in that they're rare, but when they occur, they're deadly. They're caused by the complex combination of a lot of different factors. They're poorly understood until fairly recently. If you read back over time, people describe weather events like tornadoes and hurricanes through simple folk explanations. The gods are angry and so on. And they were not well understood, hard to predict, impossible to know when they were going to occur. But this understanding and ability to predict has gotten much better recently as we've gotten better data, as technology has improved. And so we now know, taking tornadoes as an example, what are the high risk places in the US, the middle of the country? When are the high risk periods in terms of months of the year? With better consistent monitoring through radar, we've gotten a better sense of when these things are going to occur. Through sensors, weather balloons, measures of wind speed, air temperature, water temperature, and so on, we're getting a better understanding of the causes of these events, and we're getting better at predicting them. And there's an ongoing science in this area that tells us how and why hurricanes, tornadoes occur. Hurricanes we can predict now weeks in advance, tornadoes hours in advance, and this we can't prevent them, but this helps us prevent the loss of life due to them. We want to take the same approach with suicide, and the idea here is if we can get advances in technology into our hands and use them in the right way, we can better understand um, someone's risk and better help prevent outcomes like suicide, substance use, violent events, and so on. And taking the weather analogy just one step further, many of us, I certainly do, use a weather app on my phone to understand day by day, hour by hour, sometimes minute by minute, what's going to happen around me weather-wise. Can we use the same kind of approach to get an individualized understanding of people's risk for suicide? And so with the time I have today, I'm going to focus on using digital and computational advances to try and answer a few big questions about suicide prediction and prevention. And I'll spend maybe 10 minutes on each of these and then want to save the rest of whatever time I have for questions and discussion. So first I'll talk about trying to better understand who is at risk for suicide, and I'll talk about some recent exciting advances in this area. I'll then talk about when suicide risk is greatest and what we're learning about how we can use new technologies, smartphones, wearable sensors, and so on to better understand how risk changes over time within a person. And then I'll spend some time talking about what I think most of us are most interested in, and that's how can we decrease this risk, not just overall, but in the moments when someone's risk is elevated. So I'm going to start talking about who's at risk for suicide. And I'll note we have made some advances in this area. We have identified risk factors for suicide. And I'm going to refer at a few different points to this meta-analysis, this study of studies that was done by Joe Franklin and team. And what the study did was look at all of the research that's been published over the past 50 years, 50, about what we've learned about predicting suicide. And one thing the study found was this is a plot of the leading risk factors for suicide death. And you'll see the main buckets here on the horizontal axis. And on the vertical axis, these are odds ratios. I'll show a few different slides with odds ratios. What these effectively are, for those who aren't familiar, is numbers that represent what is the increase in the odds or likelihood, roughly, of an outcome, in this case, suicide, given the presence of some risk factor? So, how much are your odds increasing? If you have depression versus someone without depression, how much does that increase your risk of suicide death? An odds ratio of 1 means there's no difference. Anything above 1 suggests there's an increase in the likelihood of this outcome given the presence of a risk factor. I'll note for treatment, we see the strongest odds ratio. Being in treatment is associated with a threefold increase in your odds of dying by suicide. We don't think this is because treatment's harming people, but as I mentioned, 50% of people who die by suicide saw a clinician in the months before their death. I think we're doing a pretty good job of getting people at risk into treatment. It's from there that we need to really focus on. The biggest thing I want to note here is there's no silver bullet here in terms of prediction. All of our strongest risk factors have an odds ratio between 1 and 1.5. So having a family history of suicide, having psychopathology, having meeting criteria for a mental disorder, having prior suicidal thoughts and behaviors, each of these things ticks up your risk a little bit. Suicide results from the combination of a lot of risk factors, each with relatively small effects. Unfortunately, literally 99% of all of the analyses that have been done in published studies have looked at one risk factor at a time. What's the result of having depression on your suicide risk? What about having child trauma? What about having stressful life events and so on? What we really need to do a better job of is combining information about risk factors in a way that clinicians can use. And so I'm going to show some studies that have taken some big leaps in trying to do this, starting about 10 years ago with work led by Ron Kessler and colleagues at Harvard Medical School. And what this team tried to do is try and get better at predicting which patients are going to die by suicide in the year after a psychiatric hospitalization, which, as I mentioned earlier, is a really high risk time for suicide. You would think that someone goes for inpatient care for suicide risk, that they're going to be better after that. But in fact, a 5-day stay in the hospital, 10-day stay in the hospital often isn't sufficient to bring down risk. And so the post-hospital period is a time where, unfortunately, we still see a lot of risk for suicide death. And so what Kessler and team did was say, can we take data from your electronic health record, all the little codes that are electronically entered into your medical record when you're in the hospital and before, when you go to your primary care doc, there's codes that get entered and so on. Can we use machine learning applied to your medical and administrative data to create risk scores that can tell us your risk of dying by suicide after you leave the hospital? And the idea is we don't talk to any humans. We look at all of the data that are in the medical server and build models to tell us, based on all of these risk factors, who's most likely to have a suicide event after hospitalization. And Kessler and team trained a model on over 50,000 hospitalizations over a 6-year period among Army soldiers. This is part of the Army STARS study aimed at trying to prevent suicide in soldiers. And I'll show you the results. And to orient you, what is plotted here is these numbers 1 through 20 represent 20 risk bins. These are ventiles, so 5% bins. So this number 1 here on the left, this is the top 5% of risk scores. Number 2 is the 6th through 10th percentile, and so on. And on the vertical axis, this is what percent of suicides that actually happened fell into each of those 5% bins. So if this model works, what we want to see is a lot of the suicides piling up on the left. And that is in fact what we saw. So more than 50% of the suicides that occurred happened in that 5%, the top 5% bin. So if you think about looking for people at risk for suicide, like looking for a needle in a haystack, what this approach did was take a hayfield, separate it into 20 stacks, and more than half of the needles were in the first stack. So that's pretty good concentration of risk. So whereas the risk of suicide in the Army is 18 per 100,000 people, in this top 5% bin, it was 3,800 per 100,000. That's a high concentration of risk. However, on the flip side, let's call that 4,000 per 100,000, or 4 out of 100. That means only 4 out of every 100 people in this bin actually died by suicide. 96 out of 100 didn't. And this is I zoom in on this because this is a characteristic of work in this area more generally. Suicide's a fairly low base rate behavior. So even our best models are going to have a lot of false positives. There's a lot of people who are going to put a flag up saying this person's at risk, and they don't end up dying by suicide. So we have to bake that into our consideration and into our approach. An interesting wrinkle, though, is in that top 5%, if people didn't die by suicide, 4 out of 100 did, about half of them had what we would think of as a negative outcome. They either died by suicide or they died by accident, they made a suicide attempt, or they were rehospitalized. This is another interesting point. If we broaden our outcome variable here, these models become much more tractionable, much more useful. If I tell you only 4 out of 100 people in this bin are going to die by suicide, that might raise a challenge in terms of, well, how useful is this model on the ground? But if I told you we can identify 5% of your patients or students or whoever, and half of them are going to have an event that we want to prevent in the next year, so let's do something about it, that becomes much more actionable. I know this is done not talking to a single patient. This is all making better use of data that are already sitting in our dormant in our medical records. This is done in the Army. Another research team led by Yuval Barak-Koren with senior authors Jordan Smoller and Ben Rice at Harvard Medical School did the same thing using data from the Harvard healthcare system, the Partners healthcare system as it's called, with very similar results, and then replicated that in 5 healthcare systems around the country with very similar results, showing this approach can generalize. If you think about putting an app on your phone that everyone can use, this is like building a tool that we can plug into a medical record system or any kind of administrative system to scan across records and identify who's at risk for suicide. So exciting, we think, use of technology to try and better find people at risk so that we can intervene and better help them. In terms of next steps, what if we add additional streams of data to our model? Can we get better at identifying who's at risk and at decreasing that false positive rate? So in a follow-up study, we approached 2,000 patients passing through our local emergency department who came into the hospital saying either I'm thinking about suicide or they had an increase in psychiatric symptoms, symptoms of psychosis, bipolar disorder, alcohol, substance use, and so on. And we applied the same machine learning model to their electronic health record, exactly as in the prior study. But we also asked patients and clinicians for information about that patient's risk. When patients came into the emergency room, we ran this algorithm on their medical record, but we also gave them an iPad and asked them a list of risk factors, about 70 risk factors for suicide that generally aren't picked up in the medical record. Are you homeless? Are you employed? Are you feeling isolated? Are you feeling lonely? Are you feeling hopeless? We also ask clinicians, what's the likelihood that this patient in front of you is going to make a suicide attempt in the next month? We ran analyses to see, can we improve our model by adding in patient perspective, clinician perspective? It turns out clinicians, and I'm a clinician myself, performed worst overall. I'm going to show you values that are area under the curve or AUC. These range from 0 to 1. 0.5 is a coin toss, basically, in terms of your prediction. Higher is better. Clinicians do a little better than chance, but they don't perform as well as the machine learning algorithm applied to electronic health record. And actually, our best prediction was from the machine learning model supplemented with patients' self-report on the iPad. And here, our false positive rate dropped from 96% down to 70%. So 30% of people that we said were at high risk actually made a suicide attempt in the next month. So for clinicians, if we can tell you this patient's at risk and 1 in 3 of those patients is going to make an attempt in the next month, if not intervened upon, this perhaps could be helpful in clinicians' decision-making process. We found that a 20-item self-report version of this that can be administered in 3 or 4 minutes performed as well as the full 70 questions. So this can be done pretty quickly in the emergency room. And we're now running a 4,000-person trial, randomized controlled trial at 4 Boston area hospitals with funding from the National Institute of Health to test whether giving this information to clinicians, is this patient in front of you at high, moderate, low risk? Does this lead to better outcomes? Can we decrease the risk of suicide attempt by hospitalizing high-risk patients, not hospitalizing low-risk patients, thus improving outcomes? So hopefully in the next few years, we'll have some results to share. But I did want to note this is an area where technology is increasingly being used to better understand the data that we already have in front of us. In terms of one last note on this, what factors go into these models, which is a common question people ask. This is a plot, again, showing odds ratios for each of the different classes or categories of things that are in a patient's medical record broadly. A lot of the action, not surprisingly, is in the area of mental codes, mental health codes, things like having a substance use, personality disorder, alcohol use disorder, impulse control disorder, schizophrenia related disorder, mood disorder, all of these things, known risk factors, increase your risk. So that's not surprising. So a lot of the things that go into this model are the risk factors that you might already know about. It's just these models tag them, weight them, combine them, and present them to clinicians in a way that's really easily usable. Importantly, though, there's a lot of action down here as well. So, accidental injuries, poisonings, skin conditions, digestive problems, perhaps due to overdose, also increase your risk. And we think this is speculation, but we think what's happening here is people are coming into the hospital in earlier visits saying, I accidentally took too much medication, I accidentally cut myself, I accidentally burned myself. And these aren't getting picked up by ED docs as being at risk for suicide, but they are predictive of later suicidal behavior. So this is an area where this approach can find things in the record that maybe our mental health clinicians don't know about and aren't able to make use of. So I want to now switch gears to talk about trying to better understand, once we find people who are at risk in the next month or year, can we get better understanding when risk is highest? So as clinicians, and I would venture to guess most of you on this Zoom call are clinicians or work in some clinical capacity or are interested in this area, as I am. What we really want to know as clinicians is who's at risk for suicide now. I was very excited, frankly, by the earlier findings showing we can predict suicide attempts in the next month. My clinician colleagues who work in the ED, not so excited. They said, so what? We don't want to know next month. We want to know today, tomorrow, in the next week. What can we do to better shorten that window? So when we looked at the literature to see what time period do existing studies cover, going back to that meta-analysis, this is what we find. So what this pie chart shows is how much time passes, if we look at the published literature over the past 50 years, between when an assessment is done and an outcome is measured. And we see that in about a quarter of all studies, it's about 10 years or more. So at 25%, exactly 27% of all the studies we've done as researchers over the past 50 years trying to predict suicide, the results show the prediction of suicide death 10 years or more into the future. Although it's impressive if you can predict something that happens 10 years into the future, it's not very useful clinically. About another quarter of studies predict 5 to 10 years into the future, and you get the idea. What percent of studies predict the time in the time window clinicians are really interested in? Let's say next 1 month. It's 0.1% of all studies. So literally 99.9% of the studies that we've been doing are focused on time windows that are suboptimal for clinicians. So we need better data on the natural unfolding of suicidal thoughts and behaviors. This is not a new idea. Folks have been saying this in the literature for decades. Nico Tinbergen won a Nobel Prize, and he noted that psychology is so far behind as a science because we skipped the basic descriptive stage that many other natural sciences, chemistry, biology, ecology, and so on, have gone through. And my former colleague, Jerry Kagan, argued the same thing. I'll paraphrase. What we psychologists do is rather than go out and study the thing we're interested in nature, we create some artificial lab-based proxy in the form of behavioral studies, brain imaging studies, EEG studies, and so on. We skip the stage where we find something that's naturally interesting and puzzling, and we observe it out in nature. We're now, with the development of new technology, able to do that. So about 20 years ago, we did a study. Smartphones weren't yet available widely, but there was this new technology at the time called Palm Pilot. We did a study with funding from the American Foundation for Suicide Prevention, where we gave Palm Pilots, the cutting edge technology at the time, to a sample of 30 kids who were engaging in self-injury and suicidal thoughts. And we asked them to record their thoughts and behaviors twice a day over 2 weeks, and started to understand how self-injurious and suicidal thoughts emerge naturally. Over the past 20, 30 years, this figure goes up to about 10 years ago, the number of studies using ecological momentary assessment, as it's called, or real-time monitoring, has just skyrocketed. And now, 95 plus percent of adolescents and adults in the US carry a smartphone with them. And this allows us to get much better data from people in their natural environment about their experience of suicidal thoughts. And so, for the past about 10 years now, our group, other groups as well, I know folks at Pittsburgh are doing this, at Columbia, at other places around the world. We find people who are having thoughts of suicide, and with their consent, we put an app on their phone that pings them with a quickie survey 4 to 6 times a day. We started doing this work with adults. We now do it with adolescents as well. And we initially started following them for 1 month just to try and get a sense of, if you're having thoughts of suicide, what does that look like? What's the ebb and flow of suicidal thinking? And we asked people questions like this, exactly like this. Right now, how intense is your desire to kill yourself? How strong is your intention to kill yourself? How strong is your ability to resist that urge to kill yourself right now? So that one's reverse coded. One thing that you might be wondering is this harmful? Is it harmful to ask people about suicide? Is it going to put the idea in their head or make them more distressed? In a word, no. And there have been a number of studies that have asked and answered this question. The classic one is done by our colleague Madeline Gould at Columbia, who now 20 years ago did an experiment asking people about suicide or not, adolescents, and found pretty clearly asking people about suicide does not increase their distress, does not make them more suicidal. If you remember nothing else from what I say today, I would encourage you, if you think someone is at risk for suicide, you should ask them. It is very unlikely to make them overly distressed or to increase their risk or to give them the idea. You're here today. A lot of us are, I talk about suicide, think about suicide every day. It does not give me the idea. It does not make me more likely to want to die by suicide. What about repeatedly showing images about suicidal ideation or non-suicidal self-injury, like a lot of our behavioral tasks do? We might show images of nooses and pill bottles to try and get a sense of how people are thinking about suicide. Does that cause harm or distress? Our colleague Christine Cha, now at Yale University, has done a number of studies showing this does not increase people's distress or suicide ideation. And one of our former students, Daniel Coppersmith, who's now a professor at UMass Amherst, did a study using smartphones where he pinged people up to 6 times an hour. Are you suicidal? Are you thinking about suicide now? How about now? How about now? How about now? And he experimentally did this and found that when you ask people versus when you don't ask people, you do not see more distress. You do not see increase in suicidal thinking. So it is safe to do this kind of questioning. So what do we learn? And knowing that this is safe, what do we learn about the variability of suicidal thoughts? This is work led by one of our former postdocs, Evan Kleiman, who's now a professor at Rutgers University, doing work on suicide. What we found is this. This is what suicidal thoughts look like in a sample of about 50 people. Each gray tile is a different research participant. From left to right is 1 month passage of time. On the vertical axis, this is the severity of a person's suicidal thinking, basically just adding up the questions that I mentioned earlier. What you'll notice is there's a lot of variability. If a person's having thoughts about suicide, for any given person, they're not always or never thinking about suicide. Suicidal thoughts ebb and flow. And there's a lot of variability across people. You'll see these lines generally don't look the same. We wondered, is there any consistency in the subtypes, perhaps, of suicidal thinking? So we took these same data, and when I say we, Evan took these data and used an approach called the latent profile analysis, which statistically looks for subtypes. And I'm going to show you in the next slide the same exact tiles reorganized. What we see is 5 different subtypes that vary based on the mean or average level of suicidal thinking and the variability or spread of scores. So all of these are people, these are adults in this case, who said, I'm having serious thoughts of suicide. People shown in green had low mean, low variability in suicidal thinking, a lot of zeros with some ones and twos. People in yellow, low mean, high variability. So a lot of zeros, but they're peakier. They have these periods where their suicidal thoughts become more intense. Pretty big group. In purple, moderate mean, moderate variability. People in red, smaller group, high mean, low variability. Strong thoughts of suicide, you'll note they never come down to zero. And people in blue, high mean, higher variability. Which people were most likely to have made a recent suicide attempt? It was the people in red, which post hoc makes sense. Suicide is I won't talk much about this today, but suicide is very much about escape. When we ask people why do you want to kill yourself, the primary reason we hear about 90% of the time is I want to escape seemingly intolerable circumstances. So it makes sense if you're constantly thinking about suicide, you don't have escape from those thoughts, from what you're experiencing, that you'd be most at risk. Uh, Replication is, of course, very important of science. This is one small sample. I will note, though, we collected data on a second sample, ran a latent profile analysis, same results. We ran another 300 adults, 300 adolescents, very similar results. So I think this is a pretty robust pattern in terms of what suicidal thoughts look like. We're also learning about the duration of suicidal thoughts using this approach. If a person in a given day has thoughts of suicide, knowing that they ebb and flow, how long do they last? Is it minutes? Is it hours? Daniel Coppersmith, one of our former students, again, who's now at UMass Amherst, running his own research team there, a new research lab focused on suicide. Uh, Ping people, like as I mentioned, multiple times an hour to try and get to zoom in the microscope and get a better understanding of how long suicidal thoughts last. And he learned that suicidal thoughts tend to last 1 to 3 hours. So when a person starts thinking about suicide, that tends to last 1 to 3 hours. But different levels of suicidal thinking and different components of suicidal thoughts seem to behave differently. So what this complex spaghetti and meatballs looking figure here shows is if we think about severe versus mild versus low versus zero level of suicidal thoughts, they vary in terms of how long they last. So lower level thoughts tend to last about 6 hours. Milder thoughts and severe thoughts tend to last shorter. And having zero thoughts of suicide or near zero level thoughts of suicide tend to last longer. Suicidal urges tend to last longer than suicide intent. Intent tends to last for shorter periods of time. So as we're getting better at understanding how long suicidal thoughts last, we also want to better understand what they look like for a given person. And so we're also getting better using new technology at building idiographic or person-specific models of suicidal thinking. And this is work that I'll share led by Shirley Wang, who's one of our recent PhD students who's now a professor at Yale, running a research team there, trying to better understand suicidal thoughts. And what Shirley did was take the data we have from smartphones, following people up to 6 months at a time, and she built person-specific models. So for the patient, for the student, for the child, for the adult in front of me, in orangish brown here, this is what is their, she's plotting here, suicidal urges on a 0 to 10 scale. Let me train a model on these data and then predict moving forward for this person what I think their data are going to be. And using this model where you train on half of a person's data and then make predictions does okay, but you see it's missing a lot of these peaks and troughs, frankly. So what Shirley did was use a fancier, what's called a simple Gaussian process model that doesn't wait a few weeks and do a training. It takes all of the data available up to right now and tries to predict just your next time point, and then uses those data to predict the next time point and so on. And there, the model does much better. And so the take home here is this idiographic modeling, using a person's own data to make predictions about their next time point, the next few hours, is possible. We can do pretty well. We're still missing a lot of important peaks and troughs. And these are just two patients I'm showing you here, and I happen to pick a patient for whom the model did pretty well. Full disclosure, there's a lot of patients for whom the model doesn't do very well. So what our research teams are doing is trying to get more data and build better and better and more accurate models so we can better predict, like weather prediction, make our models better so we can better, more accurately predict when there's going to be an increase in risk. We're not just relying on a person's self-report. We're also using objective, non-self-report streams of data. For instance, this is work led by one of our former trainees, Daniel Lowe, who's now running his own research team at the Child Mind Institute in New York. And what Daniel has done is use voice data that we've been collecting, signals from a person's voice, to try and better understand risk. So we've got data from over 150 people here, and this just shows the data on this vertical line. This is when they were discharged from an inpatient hospitalization for suicide risk. To the left of this line is days of data in the hospital, and to the right of this line is we collect data for about a month after discharge. So each day, a person gives us voice data, and we're analyzing those data, looking for voice signals while they're in the hospital and even after they leave the hospital to see if we can better predict when increases in suicide risk are going to occur. These are the kinds of vocal signatures, vocal features, variables that we're looking at. And we look at a few different kinds of voice samples. We do things like ask a person to say, ah, and we measure their voice that way. We ask people to read a preloaded statement. I parked my car in Harvard Yard. And we ask them to speak naturally. Tell us about your day. Tell us about what happened. And just allow people to talk and look at the natural fluctuations in their voice. There's only a few things that predict. This is predicting severity of suicidal thoughts in a given day. And you'll see the strongest signals are for our blue and red features here. These are the natural speech and the reading that give us our best signals, and natural speech tends to do best. What are these? F0, F1, F2. Suicidal thoughts tend to be predicted here by softer, slower, breathier voice, probably indicating depression, fatigue, and the strongest effects here are for, again, natural speech. To be very clear, we don't think we're going to find any kind of suicide-specific signature. Instead, we know that voice helps us understand distress, fear, negative mood, alcohol use, and so on. And so some things that we'll pick up will help us understand those psychological states, which we can piece together to get a sense of a person's risk. We're also, and this is work that's going to come out in a paper, I think next week, using ecological momentary assessment data, survey data, to predict whether a person's going to make a suicide attempt. And we've been doing for the past few years a study where we're using smartphone data to try and predict next week's suicide attempt among 600 people, 300 adults, 300 adolescents who passed through a psychiatric hospitalization. And what we're doing is using a person's data each day to try and predict whether they're going to make a suicide attempt or have a suicide-related event, which effectively is a hospitalization to prevent a suicide in the next week. Why week? We thought about and talked about building models to predict next day, next 3 days. We've already done next month and know we have to go shorter. We settled on 1 week because this is the time range that most clinical appointments happen. People tend to see their outpatient therapist, if they're seeing a therapist, once a week. So we thought it'd probably be most useful if we give clinicians information about whether their patient, when they're seeing them on a Friday, is going to make a suicide attempt or have a hospitalization over the next week before being seen again. And these are the kinds of questions that we ask. So we put apps on people's smartphone, and 6 times a day, they get a literal ping on their phone to say, please complete a survey. We ask them those 3 questions I showed you earlier, but we also ask 17 other questions about their affect. How fatigued are you? How negative are you feeling? And we have little definitions describing what we mean by these things. And for each of these, they see a little 0 to 10 slider scale, and they use their index finger to slide back saying how fatigued I am right now, how negative, how hopeless, how much I'm feeling self-hatred. Why these items? We picked these based on leading theories about suicide. So some folks suggest that you try and kill yourself or you want to kill yourself if you're feeling like you're isolated and you're a burden to others. And so we ask about feeling isolated, feeling a burden to others, feeling trapped, feeling a desire to escape, and so on. And we then use these data in predictive models to see, can we identify who's going to make a suicide attempt or have a hospitalization in the next week? And here is what we find. So and I'll pause here so you can stare at these for a moment. And sorry for presenting so many numbers. Uh, we broke out our results by adults and adolescents because we think the models are going to perhaps be a little bit different. And we broke out results based on whether we're trying to predict a suicide attempt or a suicide related event. And I'll note there's more suicide related events than there are suicide attempts, which is going to boost the numbers a little bit. Things that happen more often tend to give us better prediction metrics. Our best results overall are for predicting hospitalizations, suicide related events among adults. With the AUC, I mentioned this score can range from 0 to 1. 0.5 is no better than chance. Generally above 0.7, 0.8 is good prediction. So we get pretty good prediction here. Sensitivity is of the events, the negative events we're trying to predict, how many of those did our model raise a flag for? 87%. So we predicted 87% of hospitalizations before they occurred. Our positive predictive value is when we raised a flag saying this person's at risk, what percent of the time was this a true positive? So did the event actually occur? For reference, it was 4% in the first study that I showed, about 30% in the follow-up, and about 30% here. So 30% of the time when our model says, ding, ding, this person's at risk of a hospitalization in the next week, about a third of the time the person actually had a hospitalization. Our model does pretty well, but not quite as good for predicting actual suicide attempts in adults, and similarly for adolescent attempts and suicide-related events. So these results we think are pretty strong if we can predict 65 to 87% of negative events a week before they occur. That's good. We still have a lot of false positives. I'll note though, we in the paper do a reporting on when we have a false positive, what does that look like? Was a person totally fine and the model just fired? No, the vast majority of the time, if the model fired and the person didn't have a suicidal outcome, they were at the very top of the range, 9 or 10 out of 10 on saying, I'm depressed, I'm distressed, I'm feeling lonely, I'm feeling isolated. So we think this is a pretty actionable set of findings in terms of urging clinicians, teachers, family members to intervene when the flag goes up. Some of the strongest predictors were extreme affect scores, extreme negative affect, feeling agitated was far and away one of our biggest predictors. One of our current PhD students, Yuri Grace Ohashi, is doing an analysis where she's digging in and looking descriptively at different affective states leading up to suicide attempts to see how long is that window. If we go out over 2 weeks before, do we start to see increase in negative affect, desire to escape, and so on. And so she's looking at affective states 2 weeks before using the same sample of data, about 600 adults and adolescents. And I should probably mention this earlier. We have about almost 500 negative outcomes to try and predict in this period, which is a good, healthy number for building models. Unfortunate that we have so many of these events, but we need to get better at trying to predict them and prevent them. And we have about 120 suicide attempts and non-attempt suicide-related events that we're trying to predict here. So what do we see? And I would love your thoughts on this because this is a paper that we're currently in the process of writing. So let me break out adults and adolescents and see how these results differ. So to orient you, this is a figure showing on the rightmost part of this graph, this is day 0. So this is when an event happens. And this is going backwards in time for the 2 weeks before on a scale from 0 to 10. This figure I'm showing here is what is a person saying about their urge to kill themselves, their self-injurious thoughts and behaviors, suicide ideation urge is our little code here. For the 2 weeks leading up to, in orange, a suicide attempt, in blue, a non-suicide attempt, suicide-related event, hospitalization. And in green, this is a non-suicidal period just as our benchmark. So usually for urge, people are saying in this sample, they're around a 1. Before a suicide attempt, they're up around a 3 for about 2 weeks before. So we do see an increase in suicide urges up to 2 weeks before a suicide attempt. We see lower increases, but then a big increase in the days before for hospitalizations, which is interesting. I'll come back to that. Similarly, for negative affect, starting about 2 weeks before, we see for suicide attempts, people are coming up. And the question is, how far in advance? Our models right now are trying to predict a week out. These descriptive data suggest we might be able to predict even further in the future. We haven't tested that yet. And for hospitalizations, again, the signal really happens just a few days before that this really shoots up. And I can show you plots for all 20. I just did urge, negative affect, and escape here because I think these are psychologically interesting. Similar pattern where for suicide attempt, we see separation, clear separation between non-suicidal periods and attempt periods about 2 weeks before. For hospitalization, again, it's just a few days before this. There's low desire to escape, and then it shoots up right before the event. Now, if we turn to adolescence, different pattern overall, and we see not as much separation for suicide attempts. We do see it for urge, not really for affect. And we see huge increases in the case of hospitalization. So some take homes for us so far are, and I'd love to hear your thoughts. Kids are reporting suicide urges before a suicide attempt. They're not really, and this pattern is true for a lot of our affective states. They're not really reporting negative affect, feeling humiliated, feeling isolated, feeling burdened before a suicide attempt. So maybe it's being more concrete. They can report an urge, but they're not using their affective states. They're not interocepting as well. But we see this big increase before hospitalization. Our thought is when there's a big increase, people notice that. It's sort of a just noticeable difference. You're able to report it. Hey, I'm feeling really bad. I really feel like I want to escape. I'm feeling really agitated. Family gets adolescent to the hospital. If it creeps up slowly over time, less likely to be detected, perhaps more likely to lead to a suicide attempt. This is all speculative. Again, I'd be curious to hear if folks have other ideas about why this might be observed here. I'm noticing time. I think I'm okay on time. Nevertheless, I'll start moving into the final part of my talk. Before I do, I'll note we're really interested in translation and using these results to help clinicians, to help teachers, to help family members, to help patients, people themselves. This is just an example of a visualization we've been working on where we're looking at, for this person, their feelings of agitation and anger. And we noticed in August, I won't tell you what year, these were increasing. And then a few days after that, their suicidal thoughts started increasing. When we look at different people, it's different affective states sometimes that lead to increases, decreases in suicidal urges. And what we'd like to move towards, what we are moving towards, is developing dashboards that can help people understand themselves and their affective states and help clinicians understand what might be driving suicide risk in a given person. And we also map out behaviors, the presence of suicidal thoughts, plans, and so on. And we can map these onto suicide-related events. And so, for instance, for this person, we noticed they were having thoughts of suicide, their drinking increased, they weren't using their therapy skills or going to see their therapist. Maybe we can build and learn idiographically what's going to trigger increased risk for a given person. So we're continuing to have focus groups with clinicians and build these dashboards and test out their usefulness. We're also adding, as I mentioned with voice, additional kinds of passive data. So we're looking at GPS signals. These are data from one person, 2 different days. Imagine this overlaid onto like a Google map. On this day, the person moved around a lot. This is their geographic trace. On this day, they didn't move around very much, maybe indicative of a depressive state. We're getting data from these are for 10 different patients, their call and text heat map, how much they're reaching out to others, how much folks are reaching out to them. We're getting biosensor data on electrodermal activity, or how much your skin is sweating as a measure of emotional intensity, heart rate variability, how much you're moving around on your accelerometer, your skin temperature, and so on. So we're collecting a lot of data from people, and we've got data on now almost 1,000 people who we've been monitoring over time. We're building models to tell us who's most at risk. A big question I want to just somewhat quickly address is the ethical and safety concerns here. If we're moving to a world where we're constantly monitoring people's suicidal thoughts, their alcohol use, their substance use in real time, what's our ethical responsibility to intervene, to respond in real time? We, in the past few years, hosted a consensus meeting that Dr. Brent attended and a number of our colleagues attended, where we had a discussion about what should our guidelines be here for ethically and safely conducting digital monitoring studies with people at risk of suicide and related behaviors. So we had a consensus meeting of 24 experts that included psychiatrists, psychologists, directors of our IRB or ethics board, university lawyers, research funders, statisticians, people with lived experience, people who have been um, experiencing suicidal thoughts themselves, and a number of different um, stakeholders. And we do what's called a Delphi process, which is an approach where you bring people in where there's not an existing standard. You bring people in and say, what should the standard be? We had people fill out an anonymous survey about a bunch of different issues. We then met in person to discuss. Then we had people do an anonymous survey. And the reason we did it this way is we didn't want the loudest voices in the room to carry the decision. We want people to have anonymous, private voting, and then we'll go with what the group thinks after everyone sort of said their piece. And so we came to some clear consensus. If you're interested in doing a deeper dive, you can find this article online. Some of the top line take homes. Most people, and there's a whole science of consensus. It's funny, there's not a clear consensus in the field about what a consensus means. Is it 70% agreed? Is it 80% agreed? For this purpose, I'll show you some things that 90% or more of us agreed on. People said, don't exclude people from research because they are at high risk. This may seem obvious to some, but a lot of folks in the field say if someone's having severe thoughts of suicide, if they're really at risk, don't have them participate in research. Protect them from research. A consequence of that, though, is we don't understand these high risk states. So we don't know what they look like. We don't know what the best way to respond is. We don't develop the most effective prevention we can. Should someone be removed from a study because they move into a high risk state? Some people early on thought yes. After we discussed it, 100% said no. We should study people even if their risk increases. We shouldn't drop people out of research studies because they're having strong thoughts of suicide. Virtually 100% of people said we should require that participants provide contact information so we can reach them in the moment in case they're at high risk. Virtually everyone said we should have safety protocols for what we're going to do when someone's at risk before the study begins. And we should monitor data at least once a day. We should respond within 24 hours and so on. I'll note in our studies where we monitor people in real time, our average response time from when a person does a survey saying they're at high risk for suicide until we reach out to them is about 15, 20 minutes. So we don't wait 24 hours. We respond as quickly as we can. So those standards are still developing. The field is developing in terms of trying to get better at intervening in real time, or at least knowing when we should intervene in real time. A separate line of work is trying to develop science around what do we do in the moment to try and decrease risk. So traditionally, what we've done, and what in most cases we still do, is if someone's at risk for suicide, we think they're at risk for suicide, we encourage them to contact crisis services, either to call 911, to go to the emergency room, to contact their clinician, or if they don't have access to those things or aren't willing to engage, to call crisis services, call 988, text crisis text line. We should keep doing that. We know from our research, only about 20% of people who are encouraged to say call 988 actually follow through and do so. Similar numbers for when we encourage people to go to the emergency room, go to inpatient units, and so on. When people do go to the emergency department, go to an inpatient hospitalization, the most often used approach is to then follow that up with weekly or monthly outpatient visits. What we're arguing for and experimenting with is treatments that are delivered in real time to try and help people when they're at risk. The idea being, if you're fortunate enough to get into an effective treatment center like the STAR Center, get DBT or dialectical behavior therapy, cognitive behavior therapy, psychopharmacology. What do we do? Those are good for longer term effects to drive down risk over weeks and months. But what do we do in the moment when someone's at risk? And what we've been doing is testing out different digital interventions, and I'll show just a few samples. One is a game-like conditioning app developed by one of our former trainees, Joe Franklin. And this is an app that's sort of like if any of you have kids or once were kids, the matching game where you see tiles turned over and you have to remember, oh, Sally's face is here and I match it with Sally and I get points. We developed a very similar app. This is a matching game and you get points. And in this case, you got a few pennies per correct match. But what we're doing when we're matching is we're conditioning people we're trying to condition people to have an aversion to suicide and self-injury. So if you're in the experimental versus control condition, that Sally to Sally match isn't Sally to Sally, it's images related to suicide, and we have you pair those with naturally aversive images like snakes or spiders. So we're effectively classically conditioning people to associate internally uh, suicide with things that they are afraid of, snakes, spiders, and so on. Very simple approach. At the same time, in the same game, it's not all negative. We have self-related words, I, me, mine, and positive images, literally puppies, rainbows, and so on. So we want to condition people to have an aversion to suicide and to feel better about themselves. Sounds simple. Joe Franklin did an initial randomized controlled trial, got really positive effects with 20 to 60% reductions in suicidal and non-suicidal self-injury behavior over the next 30 days. Didn't believe it. We didn't believe it. So he did another trial and published in this paper 3 of these trials together. Pretty robust results showing that if people do this game, people in the control condition, who just did neutral pairings compared to people in the treatment condition, those in the treatment condition saw significant reductions in their suicidal self-injurious behavior for 30 days. We then followed them for another 30 days without playing the game, and the effect washed away. So what we learned is this can work, but a month isn't a long enough time. And those effects were explained by what we thought they should be. People who felt better about themselves and worse about self-injury saw the biggest results. So it seemed to work for the reasons that we thought it would work. A few other examples. We're also using social media platforms and text-based platforms. This is work led by one of our former trainees, Adam Jaruzelski, who's now a professor at Mass General Hospital, Harvard Medical School, where we used a text-based platform to find people who are chatting about suicide, pop into their text. We scanned 40,000 participants over just 5 weeks. This kind of work can happen with technology very quickly. Found 1,500 people at risk using a machine learning driven algorithm. And for half of them, for all of them, we said, you're talking about suicide. We think you might benefit from calling crisis services. For half of them, we left them alone. For the other half, we said, if are you gonna contact crisis services? If they said no, we gave them this little chatbot driven barrier reduction intervention. What are the reasons you're not going to call the crisis hotline? I just want to chat. I don't want to talk to anybody. I don't want the police coming. I don't want to talk to a professional, whatever the case was. Whatever they clicked on, we had a little explanation for why that shouldn't be a big concern. No police, for instance. We had a tile turnover saying, actually, it's very unlikely that the police will get involved when you contact a crisis line. It says chatbot here. It wasn't that sophisticated. It was sort of a series of if-then statements. Very simple. What we found was this little mini intervention, light touch, led to a 23% increase in people's likelihood of reaching out to crisis services in the next few hours. Very light touch, programmed intervention, doesn't require any humans. Very safe. There was no potential for a chatbot to go off the rails or anything along those lines. Significant improvement in people's outreach to others. Another example, we teamed up with an online platform called The Mighty to do a digital bibliotherapy intervention. Bibliotherapy has been around for decades. The idea is reading as a form of therapy. This platform called themighty.com, you can check them out. They've got there's different sort of communities online. There's a cancer community, a fibromyalgia community, a diabetes community. There's a suicide-focused area, and anyone can go there, and you might go on having thoughts of suicide, having a loved one who has thoughts of suicide or sadly maybe died by suicide. And there's different kinds of blog posts you can read. What we did was evaluate what blog posts people find most helpful. We found 14 of them. Oops, I didn't mean for those fireworks to go off in my background, but I'm from New Jersey, so a lot of hand motions. And we assigned people who came to the platform with suicidal thoughts to get 14 stories, one per day for 2 weeks, assigned to them, sent to their email to them, that we thought would be helpful. 14 people in a control condition. And we saw significant reductions in suicidal thinking for people who got the helpful stories. There were stories like, I myself struggled with suicidal thoughts and I worked through it, or I lost someone to suicide that was dear to me, and this is how it affected me. And these stories seem to work by increasing people's hope and or increasing their feelings of connectedness. Again, very light touch intervention with significant positive results. Another example of how we can use technology to help improve things. I see that I'm at just about an hour, so I'll wrap this up in talking about just-in-time adaptive interventions, or JEDIs, as they're called. This is a new approach where we use a person's smartphone and sensor data to guide the delivery of individualized interventions right when people need them. So just in time. CBT, DBT, you might get once per week. These are interventions that are programmed to pop up when you need them most. If you're interested in this concept, um, Inbal Billy is her name. Noam Shani and Susan Murphy are some of the leaders in this area. I would encourage you to check out their work. Here's a few of their papers, and we wrote a paper with them a few years ago on applying this general approach to the study of suicide. And as just a few quick examples, Kate Bentley, a researcher who's been working with us for a number of years, implemented a version of this where when we're monitoring people at risk for suicide, when they say they're having strong thoughts of suicide, we emerge on their phone an encouragement to use skills that they learned. And we found in this initial study, this is feasible, people find it acceptable, it increases their use of skills with stronger effects when we personalize the message to the person. Again, a common theme that emerges here is the more we can tailor this to people, the more personal it is, the better the results. And Daniel Coppersmith, again, did a similar study using a chatbot-based intervention. A cute little guy we called a resource bot, and one of our research assistants drew this up. Again, feasible, acceptable, high level of engagement. 87% of the time when it was deployed, people engaged with resource bot. Interestingly, 0% of the time when resource bot encouraged them to call crisis services, did they actually do so. And I note this to say, these are not all successes. Sometimes we can get people to engage, but not to follow up with the thing we want them to do. This is going to be an iterative process. And these are just some examples of the kinds of projects that are happening with a lot of our emerging scholars. So I think the future is hopeful in this area. So in conclusion, there's a lot of opportunities for advance here using new technology if we use them thoughtfully and apply them where there are gaps in the literature and in the field. We're getting better at using electronic health records and other data sources, social media platforms, to identify people at risk. We're getting better at identifying when people are at risk, and we're starting to build a toolbox of real-time interventions. There's still a lot of open questions. How do we best deliver this information about risk from our algorithms to clinicians, to patients themselves? Still a lot of questions about the ethics of monitoring and intervening during these high-risk periods. And there's still a lot to figure out regarding how do we ethically, effectively balance humans and computers in taking advantage of what these approaches have to offer in terms of scalability and dissemination, while maintaining a human element and making sure that we're keeping people safe and honoring people as humans and meeting them where they are with humanity, literally. So I want to end there and thank our very generous funding sources and acknowledge the invaluable contributions of all of, this is not all of them, many of the folks who have helped with this work. And I want to thank you again for inviting me here and for your time and attention. And with that, if I have left sufficient time, I think we have some time for questions and discussion.
Matt, thank you. That was really brilliant. And we have a lot of questions, which is usually a good sign.
I thought you were going to
So,
say your microphone wasn't on, start over or something like that, but I'm glad to hear you heard what I said.
okay. So, one question was, have there been any studies about the impact of different types of interventions post-discharge from hospital as being beneficial?
There are so a lot of the trials that have been done with DBT, dialectical behavior therapy, cognitive behavior therapy, brief cognitive behavior therapy from David Rudd and Craig Bryan and team have recruited people in the emergency department or inpatient unit after a suicide attempt. And so what they show is pretty consistently, encouragingly, an ability to cut in half generally people's risk of suicide reattempt. So a lot of our existing studies recruit from these very settings. Where I think we need to get better is in strengthening those results. Cutting in half is good, but we need to do better. And then moving further upstream. Most people who die by suicide die on their first suicide attempt. So it's great that we can prevent the risk of reattempt. But boy, wouldn't it be even better if we can move upstream, identify people before they've made an attempt and intervene.
Great. Thank you. Yeah, also, I think there are studies that just show that if you have an appointment within a week of discharge from the hospital, it's protective. But
Yeah.
so here's a question that I'm pretty sure you have the answer to, but it's when you're getting information from people and following them up, whether it's by questionnaire, email, or whatever, what happens? What are the outcomes of people who don't fill out the surveys or aren't or
Yeah. It's a great question. We have one of our researchers, Chloe Raska, who's a PhD student with us, is looking at exactly this. So we have a lot of missingness, meaning people get surveys and they don't fill them out. Um, and we have a particularly concerning kind of missingness, which is they fill out their survey, but they don't fill out the questions about suicide. And what we know from Army Stars, for instance, is if we follow people over years, answering survey questions but leaving blank questions about suicide is a very robust predictor of making a suicide attempt over a long period of time. And what Chloe's finding is short term, filling out surveys but leaving blank the suicide question is associated with an increase in self-reported suicidal thinking in the next survey. So it does seem to be an important signal when you leave the suicide questions blank. The broader question is, what does missingness in general mean? And that is a little bit more, I think, complex. Missingness overall so far in our analyses does not predict negative outcomes. It doesn't, stopping doing surveys for some period of time doesn't mean you have a higher risk of suicide attempt. But we're not stopping there, and we're testing models that look for moderation effects or interactions. I think back to our mutual colleague Alan Kasdan, who's done really nice work on treating child conduct problems. And one thing that's always stuck with me is families who stop coming in for treatment. If you follow them over time, about a third of them, their kids look as good as kids who went through the whole treatment. So some people stop coming, and they stop coming because they got better. And some people stop coming because other reasons, and they don't have as strong of an outcome. I suspect the same might be true here. When people stop doing surveys, if they stop doing surveys when they're on a negative trajectory, perhaps that signals trouble. But if they're on a positive trajectory, perhaps that signals they're done with us and they're done participating and they're doing well. So we're trying to sort of build models that test that hypothesis um, to better understand how we use missingness in a way that helps inform our prediction.
great, thank you. Another question about the match game that Joe
Yeah.
Franklin developed. The question is, has there been a thought about trying to make that more personalized? And I mean, a bigger question is, whatever happened to it? Is there more that can be done with it? Because the
Yeah.
results were promising.
Yeah. It's a great question. This is an area where there's been too much of a lag in initial study and then follow up on it, and it has to do a little bit with Joe Franklin did this work and was a leader in it, and now is working in industry, and so we academic partners haven't done a fast enough job of picking it up and moving it forward. We actually have an NIH funded trial now that we're doing at Franciscan Children's and Boston Children's Hospital in Boston, modifying this task, this treatment for kids and making it more personalized, just as suggested. And we're in the process of doing the trial now, and hopefully in the next year or so we'll have results. And our researcher Adam Jarzewski, who I mentioned earlier, is just got funded by NIH to do a follow-up adult version of this. And in both cases, it tailors the intervention to the person and administers the intervention for a longer period of time. So we're following up on that. The early findings saying a month isn't long enough. What if you have people do it for 8 weeks rather than 4 weeks?
Right. Okay. Thank you. There are a couple questions about privacy and,
Yeah.
I think to what extent do people object? What are the privacy concerns? And I would also add to that, when when people are running these algorithms about prediction, and it goes into the medical record, what are the negative consequences of that? So just
Yeah,
about the issues of privacy and how we think we ought to be dealing with it.
very carefully. Yeah, I mean, it's a really important question, and I could talk for hours about it. It goes through every aspect of what we do. Um, Thinking about the first part of my talk, where we're building predictive models from people's medical records. There's some indication that these models become more accurate if we bring in outside data. You can buy data from um, sources, LexisNexis, and other places. You can get access to data on what are people buying at Whole Foods? How much alcohol are you buying? Is there a restraining order against you? Have you bought a firearm recently? And so on. And when we port in information from these sources, we can improve the model. But should we? And if we're giving your risk score to your clinician, then this is an open question. I don't know the answer, but for me, it would be a little creepy if I went to my primary care doc for my checkup and they said, "Hey, I noticed that you're buying a lot of wine at Whole Foods, and I noticed you bought it. Like, what are you doing in my Whole Foods account? This is, so it feels like it crosses a line. So just because we can do something doesn't mean we should do something. So we think very carefully about this and we're trying to figure out, as many of us, many scientists are trying to figure out, and in collaboration with folks in healthcare and folks in industry, how do we do this in a way that's ethical and respects people's privacy while maximizing the good for them? At the same time, we all, if you're online, if you're using your phone, the people who run the website, who run Amazon, who run Google, who run Meta, who run Samsung, data are being collected from all of us through these devices, through these platforms, and they're used to sell us things. I love it. I go on Instagram and they know exactly which 1980s t-shirts I like to buy, and they show them to me, and my wife yells, "Why?" I say, "This is great. They know me and they bring me good stuff, and I buy." Some people don't like it, so information is being collected about us, and our privacy maybe is being invaded in some ways in some people's view. Um, and we're generally okay with that because we like the services we're getting. But in science, in healthcare, we're held to a higher standard. We have IRBs, we have ethic review boards, and so on. And so we have a higher bar for how we use people's data and what's okay and what's not. And so we're constantly thinking about that. And we have stakeholder groups. We meet regularly with patients and people who have lost loved ones to suicide, with frontline clinicians who are embedded in all of the work that we're doing. And we talk a lot about what's okay for us to do, what is ethical for us to do, how do we do this in a way that respects privacy and maximizes people's likelihood of having good health outcomes. So I don't have a quick answer other than to say it is sort of the water that we swim in, and we're constantly thinking about these issues.
I think we have time for a couple more questions. So,
Okay.
um, one is, have there, what do we know about how well these models work across different racial and socioeconomic strata? And is there bias or differences in ability to predict?
Yeah, it's a great question, and also something we think a lot about and have researchers on our team who are explicitly asking these questions. Um, The good news so far is, yes, if a model is trained with data in which there are biases, those biases can be baked into the model. And so what we're doing with, for instance, our electronic health record prediction is we have our overall model, and we're looking to see how well does it work with older people versus younger people, males versus females, different races, different ethnicities, and so on. Overall, if we take broad strokes, the model seems to work pretty well across genders and races and ethnicities and so on. With a caveat, as we split the data up to smaller and smaller bins, our models become much noisier and less reliable because ultimately the limiting factor for suicide research is the number of suicide-related events that we have. And the smaller the bins get, the smaller number of outcomes, the harder it is to get good, reliable models. So, for instance, in our smartphone work, we're looking to see how well does the model do predicting next week attempts for Black participants, for Asian American and Pacific Islander participants. And the model seems to do okay, but it's much noisier because we have fewer people in those analyses. Our samples are representative of the Boston area, so we get who's coming into the hospitals and so on. So we need to do a better job moving forward of uh, intentionally recruiting a broader range of participants so that we can more clearly answer these questions. So, like with privacy, this is something that's baked into what we're doing, and we're iteratively trying to get better at doing this. And I think we struggle with this is I don't know that there's a right answer here is how specific versus general to make these models. So we sometimes say, well, we should have a different model for males than for females. But what about people who are non-binary? We did some work on multiple sclerosis and built a multiple sclerosis specific model, and it does pretty well. And early in your diagnosis, getting a diagnosis, there's all kinds of features that are MS specific that seem to help the model do really well. But one thing that we wonder, like, how many of these models can we have? Should we have a MS for males and females and younger and older? So the trick is going to be, I think, tailoring this in a way that we have a good general model that perhaps then can be tweaked based on some important characteristics. But this is something that we're iterating over and thinking carefully about.
The last question. Um, what can we do if we develop digital interventions, what can we do to encourage people to use them?
That is the $60,000 question. There's a lot of digital mental health apps out there, probably one per person in the US, and a lot of apps. And we all download. I download a lot of apps. Most of them I don't use. So how do we? I think the key is going to be building these into people's. I'll say workflow sounds very corporate speak, but building them into people's daily lives so that we're embedding in people's lives in a way that's natural and helpful and not creepy and invading people's privacy. Um, so the easier, the more friction we can reduce and get into people's everyday lives, I think the better we'll do. Uh, and we're moving towards a sort of cyborg state where we've got these digital appendages that walk around with us and listen to us and respond to us. But again, we don't want to do this in a creepy privacy invasion way or in a way that gets into people's lives to help with their mental health and sells them ads and so on. So how do we do this in a way that's maximally useful? I think that's going to be the key. That creating something we know very well, creating something, if you build it, they won't come. If building a tool that people don't use is only going to be so helpful.
Right.
But I think there's a science to implementation work. I think that there's an art to it as well, and we just need to here too. I think iterate and try and get better and better, and listen to the consumer, listen to the user, listen to the person struggling with suicidal thoughts, the family members, and figure out how do we do this all together in a way that tries to bend the curve.
Is there anything you think that you didn't have time to say that you'd like to leave us with?
If anything, I think this is great. Thank you again for having me. The thing I'd like to end with, I think, is a message of hope. I've been doing this work now for 30 or so years, and boy, it's a really exciting time. I think the number of people moving into this field, the meetings like this where we're talking about suicide in an open way, the accuracy of our prediction models, the speed with which the work is moving forward, I'm really hopeful. And I mention that in part because it's easy to lose hope these days, and there's a lot of gloom and doom and decrease in funding, and it gets hard for people to access care. Uh, as we were saying before we came on live here, I think we've all got to do what we can to keep this ship on the water and keep moving forward because suicide is not going to stop because we want it to stop. So even though the conditions are tough right now in the world and for science and for clinical care and for reimbursement, so we've got to keep going. We've got to keep working together. And I get great hope from meetings like this and from the new folks who are coming into the field, the families who are engaging, the clinicians, the educators, and so on. So that's if I can leave with any message, it's that one. Thank you all for all that you're doing.
Yeah, thanks, Matt. And part of what of some of the great stuff that you're doing is all the brilliant students that you've trained.
Here, here.
So,
I
all
had
right.
one good idea once, and as my wife tells me, back in 1993, I think it was. But other than that, it's finding really smart students and clinicians and patients and resourcing them and working together on this stuff.
Anyway, thank you very much. This is really terrific,
Thank
and we
you. Thank
really
you, everyone.
appreciate it.
Thank you for joining us, Dr. Schonfeld. Would you like to go ahead and test your slides?
Will do.
All right, let me stop my share.
Okay.
All right, go ahead and share your screen whenever you're ready.
Okay.
All right, I see PowerPoint and I see the full slide. Perfect.
Okay.
All right, I'm going to go ahead and stop your share. Thank
Okay.
you everybody for attending. We will resume coming back from our break at 10:15 Eastern Time. Again, we will resume at 10:15 a.m. Eastern Time. Thank you.
you wanna use me, then you gotta use me till I'm gone. I'm not a fallen angel, I just fell behind. I'm out of luck and I'm out of time. If you don't wanna love me, let me go. I'm running for the last train. I'm running for the last train home. If you wanna know me, then you gotta know me through and through. And if you're gonna hurt me, then you gotta hold me next to you.
My video. James, can you hear me? My video is not it's coming off. There we go. Okay. Is that working now?
Yes, we can see and hear you.
Wonderful. So good morning. My name is Paula McCommons, and on behalf of Star Center Outreach, welcome. It is my pleasure to introduce our next keynote speaker, Dr. David Schonfeld. Although he asked that I keep his introduction brief to allow more time for questions and comments, I would be remiss if I did not acknowledge that he is generously joining us this morning from California. We appreciate his early rising to be with us. Dr. Schonfeld is a developmental behavioral pediatrician by training, a professor of clinical pediatrics at the University of Southern California, Keck School of Medicine, and is the founder and director of the National Center for School Crisis and Bereavement at Children's Hospital, Los Angeles. NCSCB is a resource that we widely share through our Star Center outreach efforts, and one that he will speak more about during his remarks. For more than 3 decades, Dr. Schonfeld has worked alongside schools and communities following deaths by suicide and other traumatic losses, helping adults respond in ways that support grieving students, reduce risk for further harm, and promote resilience and healing. Dr. Schonfeld's work is deeply aligned with the mission of Star Center Outreach, emphasizing prevention, postvention, and practical guidance for those who support youth at risk. We are honored that he could join us today. Dr. Schonfeld.
All right. Well, good morning, or I guess it's morning everywhere in the United States at this point. So thank you for welcoming me. So what I'm going to do is talk a little bit about how we support children, families, and communities after a death by suicide. And I'm going to be focusing on predominantly community-based responses or school-based responses, but a lot of the same strategies apply if you're working with an individual family. So as mentioned, I'm going to introduce you briefly to the National Center, just so you know of it as a free resource for you to use. The center was established in 2005, but it was actually an extension of a program that I started at Yale over 35 years ago. And the center was created to promote an appreciation of the role that schools can serve to support students, staff, and families at times of both crisis and loss, to enhance training and professional education programs in those areas, and to serve as a resource for information, training materials, consultation, and technical assistance. And a lot of this consultation and technical assistance is provided at no cost to the school or to the community. So through a transdisciplinary team of medical, mental health, and school professionals, the center provides confidential, on-site or remote technical assistance and consultation geared predominantly to school leadership or community leadership and other professionals. We offer practical, timely advice and via a 24/7 toll-free number and informational email. So if you call after hours, we're in the West Coast, so after hours for us is a little different than the East Coast. But if you call after hours, you'll actually get hospital operators who can connect us on call at any point. We provide ongoing support, not just in the immediate aftermath of a crisis, but also throughout the long-term recovery period. We offer educational resources and crisis management tools that can be freely downloaded from our website. And we do provide school staff training and community presentations and professional development for a wide range of professional audiences. Our approach is a little different than some places, and our philosophy is that a school or community response to a crisis is not the same as a clinical approach applied to every child in that school or community. I think if we look at our experiences throughout the pandemic, but also school and community shootings and escalating severe natural disasters, and a wide range of other types of community crisis events, it really suggests we have to shift from an exclusive reliance on a medical model, which would be, screening for symptoms, further evaluation to try and reach a diagnosis, and then referral for treatment. It's kind of the medical model. I'm a developmental behavioral pediatrician, so I'm trained in the medical model. But when you have community crisis, really have to shift away from that towards a system of universal support as the primary response to crisis events. Now, and what we're trying to do then is focus on building resilience rather than delivering treatment. Now, this has to be coupled, of course, with school and community-based mental health services to provide additional support to the children and adults who require more assistance. But we feel the primary focus should be on this universal support in these community-based settings. Now, healthcare, mental health providers, and educators, and really anyone that's in a position to support children after either a community or family crisis, such as a suicide, can provide a supportive and empathic response. That doesn't require that non-mental health providers like classroom teachers provide counseling, but rather that they provide an empathic presence and offer practical support. So in the setting of school, classroom educators, it would be learning support so the kids can still learn despite the crisis that has happened. I was interviewing one teacher for a video I was developing, and she told the story of one day one of her students in middle school came back after a week absence. The teacher knew that he was out because his mother was hospitalized, but he didn't realize that his mother had died during that time period. And so he told her when he arrived at the classroom, so she gave him a hug. And she said, I'm so sorry. This must be so difficult. And apparently he got embarrassed. And he said, please don't do this. So she said, okay, but I am here. If when you're ready to talk with me, just come and stop by. My door's open. All of us, our doors are open for you. But he never came back to talk about what had happened. But he did stop by several weeks later just to thank her. And when she asked why, he said, you were here and I didn't have to talk about it. And she said, I realized then sometimes children don't want to talk about it. But and she gave this metaphor. She said, it's like a dance. I'll take the first step. If the student's ready to take the next step, then we continue the dance. If not, that's okay. We can just stop and listen to the music together. And I think that's a lot of what you really need to do is to figure out how do you listen to the music together with kids when they're in distress. So one approach for doing that we talk about in the immediate aftermath of a major crisis event is psychological first aid. And that's generally provided broadly to all of those who are impacted by the event. And it involves offering psychoeducation, helping people understand the common reactions, and more importantly, what do you do about it? And supportive services to promote effective and normative coping strategies and adjustment. It's not a treatment. It's actually just intended to accelerate the natural healing process. So it's a supportive intervention instead of a treatment intervention. And we feel that all adults should understand the likely reactions that children might have and how they can be a source of assistance and support. Because the reality is, if they're not prepared, particularly if they appear disinterested, say they just don't feel this is something that they can do, so they don't do it, then that can actually cause more distress in individuals in crisis situations. I went to do some training at the Flight 93 Memorial. Flight 93 was the flight that had terrorists on board on September 11th. And the flight actually took off late because of air traffic control delays. So the passengers and crew were able to find out through cell phone communications on personal cell phones of what happened at the World Trade Center and at the Pentagon while the terrorists were still on board their plane. And so they made a collective decision to try and overpower the terrorists so that their plane wouldn't meet a similar fate and harm others. And in the process, the plane crashed outside of Pittsburgh. Hopefully some of you have been to the Flight 93 Memorial. It's a very nice memorial. It's part of the National Park Service. So anyway, we went to do the training there with other staff. And afterwards, somebody came up who worked on maintaining the grounds. And he said, I have trained my staff that if they are cutting the lawn and they see a visitor, they're to stop what they're doing, establish eye contact, and ask if they can be of assistance. And he looked at me and he said, we're not here for the grass. This is sacred ground. We're here for the visitor experience. Part of me felt like saying, well, actually, you're part of the Park Service and you are actually here for the grass. But he already knew that. The point was he knew that there was a higher purpose of what he was there to do. So I always tell people in schools, I don't care if you're a contractor dropping off water bottles. You are there for the student experience. And so everything has to have that overarching approach. And so you really should be thinking about how you equip everyone who works in whatever setting you're at to try and be able to support children when they've been through a crisis situation. So sometimes you'll find that these other individuals who aren't traditional mental health providers are in unusual positions and can actually connect with students in ways that, for example, mental health providers may not be able to. I went to one school that had a mass shooting, and I was talking to the cafeteria staff, and they said that they noted that the girls were wearing long sleeve shirts. And I asked them why they thought that was important. And they said, well, when they hold out their trays, the sleeves retract and we can see that they're cutting more. And we think that's why they're wearing long sleeve shirts. So I asked them, did you tell the mental health staff? And they just looked at me and said, no, we just work in the cafeteria. That's just our observation, but it's an important observation. I also talked with custodians in that school, and this was a high school. And one of the custodians looked at me and said, well, these kids are out of control. And I said, can you give me an example of what you saw that was out of control? And he said, well, the other day I was walking through the cafeteria and a group of students got up and they left their trays behind. And I reminded them that they hadn't bussed their trays, but they ignored me and kept walking. So I stopped them and I said, if you leave the trays on the table, no one's going to pick them up after you. So they went over, they picked up their trays, they opened the door and they threw them out of the building, turned to the custodian and said, are you happy now? They're not on the table anymore. And he looked at me and he said, these are really good kids. They would never have done that before the shooting. He said, but what worries me most is they don't do that in front of the administration, in front of the teachers, in front of their parents. We see a very different side of these kids and we're really deeply concerned about them. And then one of them said, well, yes, and they're also having sex on campus during school hours. We know who is doing it, we know where they're doing it. So they literally do see a very different side of these students than most of us do. And they're also more accessible in some situations. And so we have started doing training for these professions as well. You know, for example, bus drivers, cafeteria workers, front office staff. You really want to make sure everyone is prepared to support children in distress. Now, for some individuals, though, this psychological first aid is not going to be sufficient. And the second complementary approach involves timely and effective triage and referral in order to identify and deliver services to children who would benefit from additional mental health care. Now, we always try and bridge this, dilemma. We don't want to pathologize common reactions. So, for example, we don't want to refer to everybody who's feeling sad after somebody has died by suicide as in referring to them as being depressed. We don't want to pathologize common reactions, but we also don't want to dismiss serious reactions. And I've seen this where people will say, after a disaster, everything is normal, or validate all feelings that children have. Well, there are some feelings and reactions which are, worrisome, and suicidal ideation is one of them. I remember I was providing support to one family. I was talking to the mother. She had a young child who had had a recurrence of a brain tumor and was doing poorly at home. So I provided support up until the time the child died, but I continued to provide some support afterwards. Now, we were on different coasts, and so I had never met her. I had never met the children either, and it was all being done by phone. And so one night, several months after the child died, I was talking to the mother, and she said, I never really mentioned my other daughter as a teenager. She said, she's been really deeply affected by this. And she said, even the other day, she said she was thinking of killing herself. And I asked her, what did you do about that? And she said, well, I didn't do anything. That was 3 weeks ago. She mentioned it once. That's normal after, a sibling dies. And I said, we never assume that suicidal ideation is safe. She needs to see someone. And she said, well, it was 3 weeks ago and she hasn't repeated it. And I said, well, you should go take her to see someone now. Well, because of the time difference, the girl was actually asleep on a Friday night. So she just said, I can't wake her up to bring her in about something she said, several weeks ago. And I said, okay, well, you can bring her in tomorrow morning. And she just said, well, it's Saturday. Who would I bring her to? I'm not going to go to the emergency room. I said, no, you'll go to your pediatrician. I was actually doing this for a colleague who's a pediatrician. I said, I'll call the pediatrician and they will see you tomorrow morning. And she said, no, I think that's unnecessary. because, certainly it can wait until the week. I mean, this was, again, one comment that she made. And so I talked with her about safety over the weekend. They didn't have any firearms at home. Um, she said she did have some prescription medication. And I said, okay, what I want you to do is, as soon as you get off the call, I want you to lock up all the prescription medication until your daughter is seen on Monday. And she just said to me, I think you're really overdoing this. But I had actually volunteered to talk with her every couple weeks for almost a year at no charge. And so she said, I'll do anything you say because you've been such a support. And then I spoke with her a couple days later, and apparently the girl overdosed the following morning. And on the way back from the emergency department, she just said to her mother, what did you do with all the prescription medication? I couldn't find anything that would work. Now, I'm not suggesting that I can tell when someone is going to act on suicidal impulses. Um, and I go through that example because actually I've never met the girl. Still to this day, I have never met her. So I didn't, and I never spoke to her on the phone either. It was based solely on a concern that when someone talks about suicidal ideation, we have to take that as a mental health emergency. So this is part of what we try and do in schools is to say, look, we don't want to pathologize everyone's distress, but this is something you take as a mental health emergency and you act on it immediately. Okay, so with that caveat, let's go into some of the ways we can identify um, common types of reactions that you might see. So, and I'm going to say that the most common reaction that you will see in children after a crisis event is not actually on this slide. And that's nothing. Most children will hide their distress because either they feel it makes them somehow abnormal or they don't want to burden the adults who are also distressed around them. So we do need to monitor children more closely or refer them for someone who they can speak to in more detail if they've had significant personal exposures. So, for example, if the person who died by suicide was a close friend or was a sibling, even if they don't show any signs that they are in having any of these type of symptoms or reactions, I would still refer them to someone to talk about how they're feeling and how they're doing. But this is just in general what you may see. So the first one is fears and anxieties. So the fears may be related to the crisis itself. They're afraid someone else might die by suicide. If there was a shooting, another shooting will occur. I think most people anticipate that because it's fairly logical and straightforward. But they may also show anxiety. So they may have fears that are not linked to what happened. They may just become more fearful. And one of the signs of anxiety we often see in children, or at least shows up in school, is school avoidance. Kids will often be reluctant to separate from those that they love and care about, who are there to protect them after a crisis event, even if the crisis didn't happen in a school setting. So we've seen this, for example, after a flood that's happened in a community on the weekend while people are home, kids still don't want to separate to go to school. And it's also that the adults don't want to separate from their children either. So we talk about the fact that you really need to look for school avoidance. And if kids are not in school, reach out to them. So I always tell people, worry about the children who are showing distress, worry about the children who are not showing distress, but worry most about the children you don't see at all. And so we really have to do kind of active outreach when that occurs. Now, if you're going to be addressing children's fears, you have to actually know what they're afraid of. And children have very different fears or concerns than adults. And actually, adults have different fears and concerns among themselves. And you can't reassure people if you don't actually know what they're afraid of or concerned about. Otherwise, you really aren't offering reassurance to them, but you're telling them why you aren't worried. Physicians do this all the time. They talk about the lab results and other things that are reassuring to them, but it doesn't really address the fears or concerns and worries of their patients and their patients' families. So if each person only talks from their own perspective, I just call that arguing, and I've actually never found that to be very reassuring. So you really have to take some time to say, what are you concerned about before you move right to reassuring. We don't want to tell children that they shouldn't be worried or try and minimize their concerns, but instead help them learn to deal with their uncertainty and fear. So share with them strategies for dealing with distressing feelings rather than pretend that they don't or shouldn't exist. So the next thing on this slide is sleep problems. That could be trouble falling asleep or staying asleep, difficulty waking in the morning, nightmares, or other disruptions in sleep. I have now taken to be sure, I went to one school that had a mass shooting. I spoke with them actually before the school opened up afterwards and went over this and talked about sleep problems. And then I followed up with them later. And one of the questions was, what do we do about co-sleeping? So I've now actually started saying one of the sleep problems that you can create is if you start co-sleeping after a crisis event. If that is not something you were doing before and then that didn't align with your cultural preferences. So if you start co-sleeping, you get learned sleep associations, and it's very hard to break that kind of habit or sleep association afterwards, and it can cause more distress. So it's best to not start that as a potential coping mechanism. In addition to sleep, you can also see a change in appetite or eating. It can be either an increase or a decrease. You'll see difficulties with concentration and academic performance. And for adults, it's work performance. If you have sleep problems, you actually don't perform very well for the next day or several days afterwards. So if you imagine that that's kind of chronic or continues for a period of time, it obviously is going to have lead to problems with concentration and academic performance, but also you can have just concentration problems even if you are sleeping all right. You can see sadness and depression, and you really have to figure out how to distinguish between the two. If a student or a staff member of the school has died by suicide, it's understandable that people will feel sad. It is a sad thing that's occurred. Um, but you really are trying to discern, is it sadness or is it clinical depression? And that can be difficult for some people, and that's where I think clinicians can play an important role. If you're at all concerned that it may be moving into or changing their ability to function day to day or causing extreme depressive or sadness, then I think you do involve a clinician in the school to try and help sort that out. You can also see anger or irritability. Um, I've heard people say that, crisis brings out the best in people. I'm going to tell you, I think that's a myth. Actually, crisis events tend to make people distressed, and they tend to be more needy, demanding, self-centered, and not particularly fun or satisfying to be with. There are examples of individuals who rise to the occasion in crisis events to help others, to do selfless acts, to risk their own lives, to help those who are in need. And I think we should elevate those as we do in the media and in the stories that we tell, but they're actually outliers. Most people are just not at their best. And it isn't just the children, it's the adults. And to be quite honest, it's us as well. And so I'll get back to that later. I want to talk a little bit about taking care of yourself in these situations. Another reaction that you may see is the use of alcohol or other substance. And so substance abuse evaluation and treatment services should be part of the recovery plan for any crisis, including a suicide that's occurred. And again, this is not restricted to the children. You may see new onset or an increase in alcohol or other substance use, but you'll see that with the adults and even among mental health professionals. I went to New Orleans after Katrina on one visit, and the person who was hosting my visit was a school mental health provider. And during the workshop, I had talked about this. And as we were driving back after this, she shared with me that it was about 3 weeks after Katrina, and her daughter texted her to ask where she was after school one day because she hadn't come home right away. And apparently she texted back and said, "Oh, I'm fine. I'm at happy hour with friends at school." And her daughter just texted back, "You've been at happy hour every day since Katrina, and you don't seem happy at all to me." And she said to me, "That's when I realized I was drinking too much." And I have seen this quite frequently among professionals, that they often use alcohol as a way to kind of try to cope with their distress. And obviously, that's very problematic and generally makes matters worse. I will say that even during the pandemic, I participated at the height of the pandemic when everyone was still, at home and not returning to work situations or socializing before the vaccine was available. We had two pediatric national conferences that were held about a week apart that I attended. Both of them had virtual happy hours, and they actually encouraged the pediatric and other professional staff to get alcohol and sit in front of their camera on Zoom. And I really thought that was not the right thing to be doing. And for individuals who are vulnerable and under a great deal of distress, I think it's problematic. You can also see an increase in physical symptoms such as headaches or stomach aches or fatigue. That can be psychological distress can present as physical symptoms. We call that somatization. But actually, stress hormones have physiological effects that do worsen health. So, stress hormones can actually increase blood pressure. They can worsen diabetes control in individuals with diabetes. They can precipitate asthma attacks in individuals that are prone to asthma attacks. And so you will often see a combination of both psychological distress and physical illness presenting as physical symptoms, which is one of the challenges, particularly I find for school nurses, because they have to try and figure that out and address both of them. But you will see that really in any setting. Children may also demonstrate post-traumatic symptoms, and some will meet the criteria for post-traumatic stress disorder, especially if they view directly traumatic images related to the death. I have found, though, that we've done a pretty good job nationally of making sure that people are kind of more trauma informed, so they tend to understand and look for and recognize post-traumatic symptoms fairly commonly. So, although that is an important type of reaction, I'm not going to talk much about that unless there are questions. But I wanted to turn more to the next one, which is grief. And I think we've, as I said, done a pretty good job of becoming trauma informed, but we've not done as good a job to become grief sensitive. I went to talk with one teenager. He had been in a mass shooting in his community. And actually, the person on either side of him was shot and killed, but he was not physically injured. And he had declined counseling. He had come back to school once, but only stayed a couple hours. And the school was concerned about him because 3 weeks had passed since the shooting. So I went out to his home with his permission, and I asked him why he wasn't in counseling. And he said, all I want to do is keep talking about the shooter. And he said, I had some trauma symptoms, and he listed them. He said, I had trouble sleeping. I was jittery. I was having trouble concentrating. And he said, but those things went away after a week. And I said, well, then why aren't you in school? And he said, well, I tried going to school, but it didn't feel right being there. And I asked him why it didn't feel right. And the bottom line was it didn't feel right because his girlfriend wasn't there. She was on one side of him that night and had died. And he said being in school without her just didn't feel right. So I said, well, maybe you're grieving the death of your girlfriend. And he got quiet, thought about it, and then he said, that's it. And if someone's willing to talk to me about that, I'll go for counseling today. I just don't want to keep talking about the shooting. I think what happens is when people are in traumatic situations, they focus on the we focus on the trauma part, but we don't focus on the grief. So if you have a suicide and let's say somebody finds, you have a student, we've had this happen where a student has jumped off a balcony in a school during recess and that's been viewed by much of the student body. That is a traumatic exposure or a potentially traumatic exposure. And people focus on that, but they don't talk about the fact that the student that they know and care about has died. And so we have to make sure that we're also attending to the grief. The interventions and supports that we offer to children who are grieving are actually quite different from trauma treatments. If you think about it, this is at a very fundamental level. When you're addressing trauma, you're focusing on the person's reactions to something that happened in the past. Complex trauma, it might have happened multiple times in the past, but it's still something from the past that occurred. But support for grief instead focuses on helping people cope with loss, the persistent absence of someone they loved for the rest of their lives, rather than the way that the person died. So it really has a very different orientation and context. And as a result, some of the interventions that we use for trauma are not effective and may actually be almost inappropriate to use for grief. I was on the Sandy Hook Advisory Commission, and at one of the meetings in the spring, a parent came and told us that when she opened the yearbook, she noticed that the picture of her child had been removed, as had the photographs of every child and adult who died that day. And she just said, "What are they thinking? It's like they never existed." And I can't tell you that. I coordinated the response for the first week after Sandy Hook, but then moved out of state. So I did not continue to follow, other than being on the Sandy Hook Advisory Commission. But so I didn't speak to their yearbook committee, but I have spoken to other yearbooks who have done that. And they tell me that they're trying to remove trauma triggers. And I look at them and I say, they're not trauma triggers, they're grief triggers. And those are very different experiences. With grief triggers, it's just things that remind us of the person when they were alive. And they're actually signs of continued attachment to those that we miss and love. And individuals will tell you that they are more afraid of forgetting someone they love than of being reminded of the grief associated with them. And that's why people go to cemeteries. That's why people tell stories about people they love that died. That continued attachment they want to continue. And so I had one kid, and she said, I've had grief triggers for 4 years since my father died, but now I kind of like them because it keeps me close to my dad. So the only way through grief is through grieving. You don't want to avoid the reminders. It's not the same thing with trauma. That's actually quite different. So many adults think they're going to, say the wrong thing or do the wrong thing with grief, and they're afraid to just talk about it. And so the reality is that saying nothing is, they'll say, it's better not to say anything when someone's grieving because that'll just upset them. So it's better to say nothing. And I always tell them that saying nothing is exactly the wrong thing to say. It communicates that either you're clueless about what's happened, you are aware, but you just don't know what to do, or you don't think the child can cope even with your support. Or I think probably worst of all, that you understand what's going on and you really just don't care. And that leaves kids to grieve alone. So we really have to overcome some of that. But people say, I'm afraid I'm going to say the wrong thing. So let me go into some of the wrong things. Now, these aren't absolutely wrong, and it's all in the context of your professional talking to children as part of your job. It's very different when we're talking with our own kids, for example. But the first one is don't try and cheer up survivors. Statements like, I know it hurts right now, but it's going to be better very soon. Just allow them the time it takes for them to deal and respond to their grief. Anything that begins with at least should probably be reconsidered. At least he's not in pain anymore. I know your sister died, but at least you still have a brother. These comments are not helpful to individuals who are grieving. And it's more that the observer doesn't want to see the distress because they don't like seeing it. So they try and suppress it, or they try and solve it. And you can't solve grief in a comment. So avoid any attempt to cheer up survivors. You don't want to encourage them to be strong or cover their emotions. And you should feel free to express your feelings and demonstrate empathy. But I would avoid statements such as, I know exactly what you're going through, because you can't unless they tell you. And you don't want to say things like, you must be angry. Don't tell the person how they ought to feel, but instead ask them how they're feeling. And so in these situations, you can, for example, make observations about how you think they're doing. You can say, ever since your mother died, I've noticed that you don't talk as much in class. As long as you give the observation in a non-judgmental way, that can be supportive. I wouldn't say ever since your mother died, you're not participating enough in class. That's actually judgmental. Really, what you want to do is allow the child, or if you're working with the family, to be upset and suspend your judgment so that you're intervening only when safety or health is a concern, as I already mentioned, around suicidal ideation. Now, some people are also worried that they're going to say or do the wrong thing because they feel ill-informed about another person's culture. Cultural differences do exist specific to suicide, and it may include beliefs and religious prohibitions about suicide and cultural expectations related to disclosure and secrecy. So there are differences among cultures, including in mourning practices, But the fundamental experience of grief is actually universal. And so we can explore ways to bridge cultural differences in order to help grieving children and families of all backgrounds and beliefs. But we should start out with the common humanity that we can support people when they're distressed. Then what you could do is ask questions when you're unsure what would be most helpful for a family or an individual. And the reality is that when we make assumptions about what an individual, family, or culture does to grieve, that that may actually result in stereotypes that cloud our perceptions and make us miss opportunities to be helpful. I had the opportunity to provide support to an Amish family after a child was killed. A young child was killed, and I was over at their home, and the grandmother was showing me around at the house. And at one point, she stopped and pointed to a framed picture on the wall. And she said, "That's a picture of my granddaughter." And she told me that one day the kids were over and they were playing outside, and a tourist had stopped. He was a photographer from out of state, and he was taking pictures of the grandchildren. And so she stopped him and said, "You know, sir, we're Amish, and we actually believe that violates our religious and our cultural beliefs. We consider them graven images. I'm going to ask that you respect that and not take pictures of the children." But apparently, her granddaughter, who was about 5 at the time, was so excited because she had never had her picture taken that she said, "Grandma, he's a photographer. He's going to send us a copy. Please let him do it." Grandmother said to me, I was so embarrassed at the time. I just didn't say anything and I let it happen. And then she pointed to the picture and said, "What a gift from God. Otherwise, I wouldn't have this to remember her." So the issue is, I knew that Amish generally do not use photographs as transitional objects because it does violate their religious and cultural beliefs. But if I had communicated that, I don't think she would have been able to share with me that that's actually what she was doing. And we come from different and blended backgrounds. So you really shouldn't make assumptions of anyone's cultural beliefs or practices, but help them identify and communicate what's important to them about their cultural practices. And then you can work with them to find solutions and compromises if the realities require modifications in the cultural practices. Now, going back to the list of adjustment reactions, the next one on here is guilt. People somehow manage to find reasons to feel guilty, irrespective of their experience or role in what's happened. And obviously, with suicide, that is even more common. At some level, often unconsciously, it may feel easier to feel responsible for something you did, didn't do, or should have done than to accept it might actually have nothing to do with you. Because one of the fears that you have and anxiety that you get is this going to happen to someone else? And so if you realize you had no role in it happening to the first person, then you have to accept the fact you probably will have no role into whether or not it will happen again. So people will adopt instead this illusion of control by trying to figure out what they did wrong so that they can reassure themselves that they can change their behavior and prevent it from happening in the future. But when it's an illusion of control, it doesn't actually work, and it just leaves the person with guilt. Here, Calvin, calls for his mother, and he says, big dog knocked me down, and he stole Hobbs. I tried to catch him, but I couldn't, and now I've lost my best friend." And his mother just says, "Well, Calvin, if you wouldn't drag that tiger everywhere, things like this wouldn't happen." And he points out there's no problem so awful you can't add some guilt to it and make it even worse. So guilt is extremely common after death of all causes, but it's often more profound and challenging to address after a suicide. So I think it's important that we reassure children of their lack of responsibility for a death, even when there's no reason that you would think they were responsible. There is actually a reason to the phenomenon that I talked about. I went to speak to one class of third and fourth graders, just about death in general and how individuals respond to grief. And I spoke for like 45 minutes. And the teacher had them write letters to me, and I got them. And one of the letters was from a child who said that, and she said, "Dear Dr. Schonfeld, thank you for coming to my class and talking about what happens when someone dies. Now I know it's not my fault. My father killed himself. Have a happy Valentine's Day." And she signed her name. So I'm not suggesting that, 45-minute presentation is enough to manage the guilt, but actually is enough for people to start to express it. And that's the first step. So when guilt is persistent, it doesn't just go away in many situations. And so I often ask them, did you intend to do this? And invariably they say, no, I didn't do this intentionally. And then I ask them, what do you think it's going to take before you feel ready to forgive yourself? And then that's what we do in counseling, is try and get to that point of forgiveness. Now, when a crisis occurs, it can uncover past crisis and loss or concerns about future events. So, for example, I went to one school where there had been a shooting that had occurred in the community and a number of students had died. And I was going over training. I did training for about 4 hours with the staff. And the principal came up to me and he said, you talked about guilt during this. And actually, 2 or 3 years ago, we had 3 students who died by suicide in the school. And there were a number of staff who implied to me that if I'd been a better principal, maybe these children would still be alive. And he looked at me and goes, I have lived with this for the past several years. Where were you with this information before? And that was actually really profoundly important to him and something he talked about for several years afterwards, that he was just starting to recover from the suicide. He didn't really focus as much on the shooting that happened in the community, which was the reason why I was there. But you will find that sometimes you talk about one crisis, you just uncover something else in someone's life. So let me now turn to some unique considerations related to a school or community crisis when it is death by suicide per se. Now, as you know, suicide is the second leading cause of death for children 10 to 24 years of age. Attempts are very common, despite the likelihood that suicide is widely underreported because many are classified as unintentional or accidental. About half of US adults know someone who has died by suicide, and as a result, it's highly likely that many members of the community, including professionals of all backgrounds, will have personal experiences with suicide among family members or friends, or may have considered or attempted suicide themselves in the past. So, coupled with the persistent but unfounded concern among some people that discussion about suicide may prompt others to harm themselves that wouldn't have otherwise considered it, as well as the particularly high degree of stigma associated with suicide, it's understandable there's often reluctance on the part of school staff to discuss suicide and self-destructive behaviors openly with children, even if that would be a benefit to them. Suicide carries a stigma in our society that leaves survivors with strong feelings of guilt, shame, regret, and anger. And this slide lists some of the issues facing lost survivors. Guilt about not having noticed or given enough attention to the possible warning signs or what they said or did, which may have contributed to it. Persistent, unanswerable searching and anxiety about what they could have done to have changed this or prevented the suicide. Anxiety and fear about the vulnerability of others, I already talked about. Sadness or betrayal about not having been told by those who died about how desperate they were feeling prior to the suicide. And then anger and blame at others for not having prevented the death either. Families are often reluctant, for many of these reasons, to have suicide mentioned as a possible or likely cause of their child's death, even when the circumstances strongly suggest otherwise. I remember working with one school where the child died. He had hung himself from a tree with, I think, the string from his hoodie, and the parents said it was accidental. It was very unlikely that that was the case because this was a school-age child, but that we will see that. It's important to clarify the information to disclose about the cause of death to children in the community and school. And when appropriate, sometimes we can gently explain to families why discussion about suicide may decrease the risk that other children will die by this cause. But the family's wishes can be respected at the same time that suicide is addressed with children. For example, if children are talking about the fact that they heard it was from suicide, then the adults, like classroom educators, can, say that the family is unsure of the reason for John's death, or they feel that it's accidental, or they haven't determined the cause of the death yet. But you're talking about suicide, and suicide is unfortunately a cause of death among children your age. So we can talk about what's important to know about suicide, even though we don't know if it's at all related to this particular cause. Now, I remember talking to someone in the education field, actually at the federal level, who said, it's not a suicide until the medical examiner determines it's a suicide. And my response to him was, it's a suicide as soon as the person kills themselves. I mean, it is a suicide. And so I understand that we don't want to notify people that it's a suicide until we have confirmed that. But there are many situations where the kids know about it. I was recently involved in a case where a child died in a motor vehicle accident, um, but their peer, their sibling, texted friends that it was suicide. And so you end up, and they were still at school and they were just being informed about what had happened. So you find that kids are often confronted with this information through social media or through conversation. And so we want to make sure that we don't avoid talking about it. Now, when you do talk about suicide, you want to avoid terms or phrases that inadvertently add to the stigma. So I wouldn't say, for example, we recommend that you say things like died by suicide. And I would avoid euphemisms, especially with younger children. These euphemisms, like they're at peace, that doesn't really explain what happened. They're only conceived to be helpful by obscuring the upsetting information. And when you obscure information for children, you actually just make it difficult for them to understand what's happened. So it's particularly problematic to use these euphemisms with children. I would also avoid saying things like anything that adds to the stigma. So committed suicide may imply to some people it's a criminal act. I've also seen people talk about the fact that there's suicide attempts and then successful suicide. That's an oxymoron to be a successful suicide. So you could say instead a completed suicide or a person who died by suicide. Now, while acknowledging the individual who died and the grief of survivors who lost a friend or peer, we want to avoid glamorizing suicide. So it's important to avoid gestures that might make suicide seem appealing to depressed or isolated children, such as holding formal commemorative events. We don't want children to reach the conclusion that no one even noticed him until he killed himself. So discussion should focus on the grief of survivors after having lost someone important in their lives, or sadness for a life that ended too early, rather than focus on the means of death or suggesting that the deceased was somehow a hero or more worthwhile or noteworthy as a result of suicide. As a result, they recommend you should attempt to minimize media coverage, avoiding front page coverage, or details about the means of suicide, so as not to make suicide seem appealing to children who might appear disenfranchised or depressed. The focus of the message should be on the importance of talking with a trusted adult if you're considering harming yourself or suspect that someone you know is potentially suicidal. Information about suicide hotlines and other school and community programs for suicide prevention should be prominent in any media coverage or discussion with students. In discussions with children, you want to educate them about warning signs and symptoms and encourage children to seek help when they're concerned about others or themselves. Although we often don't know the specific reason for suicide of any one individual, whether that be a child or an adult, and it is a highly sensitive topic, it's important to avoid explanations that are overly vague or too simplistic, such as he was very, very sad and decided to kill himself, because at that point, everyone around them is very, very sad. And this might actually imply to children that suicide is a logical choice of someone who's thinking clearly and frighten them because those close to them are actually very sad. Instead, you can convey that suicide is usually the result of underlying depression or other mental health problems and/or related to alcohol or other substance abuse. Giving long lists of fairly non-specific risk factors should be avoided. So telling youth that suicide risks are greater when people are under 24 years of age, if they're under stress, if they have inadequate sleep, etc. Those long lists, I mean, that's going to include everybody in the school. So it doesn't really help discern who's at risk, and it just makes everyone scared. In presentations to children, it's also important to destigmatize seeking help for depression, other mental health problems, and substance use. Now, peers are often asked by individuals who are contemplating suicide to keep information about their suicidal thoughts or intentions as a secret. And children should be told that just as two friends don't allow their friends to drink and drive, they should never agree to keep suicidal ideations as a secret. In most situations, individuals who mention thoughts or plans of suicide are actually ambivalent about ending their life, and they will later appreciate a friend's intervention that prevented the death. But even in the rare situation where that doesn't occur, and they don't thank you afterwards, it's actually better to have a friend who's upset with you than a friend that died. So we really talk directly about you can't keep this a secret. It is not safe or appropriate. Be sure to emphasize that this advice is intended to help prevent future deaths by suicide, not to make people feel guilty if they had or now realize they should have had concerns about someone before an already completed suicide and failed to bring it to other people's attention. A major goal of suicide postvention activities is to decrease the risk of another suicide. So those closest to the deceased should be given additional support. But you also want to identify other children at greatest risk, such as individuals who may have known of the plan for suicide beforehand or believe they may have neglected, mistreated, or bullied the individual. They may also feel guilty or be blamed and scapegoated by peers if they had a particular type of relationship, such as they broke off a romantic relationship right before the suicide. Individuals experiencing depression, whether a pre-existing depression that's unrelated, or those who contemplated or attempted suicide in the past, or those with family members who are at risk or who died by suicide, may also be having more difficulties and warrant additional support. I know a lot of times people talk directly with the friends and close colleagues, and that is important, but we have to think of all these other people who are also at risk. Now, communication among schools, mental health agencies, and other groups can help monitor if there's an increase in suicide attempts or a pattern that would suggest a possible suicide cluster. That's just the occurrence of more suicides than would be expected in a certain time or location or both. That might be if there's more than one suicide in a school during a particular year, especially if those who died knew each other or were in the same peer group and or if they used a similar method for suicide. Contagion is actually relatively rare. I saw somewhere accounting for perhaps 1 to 5% of all youth suicide, but adolescents and teenagers appear to be more susceptible to imitative suicide than adults are. And so if you suspect a suicide cluster, and we've gotten involved in a number of them, then strongly consider involving experts that have experience in dealing with suicide clusters. Possible clusters within a school indicate the need to examine the school climate, explore protocols for supporting distressed students, and create a plan for building a different school environment. And this is a process, not just of recovery, but of prevention. And it isn't done in a week or a month. It requires the engagement over time of schools, parents, students, the community, and I would suggest outside experts to help you through that process. The last thing I wanted to mention is professional self-care. It's important for all professionals, but it's particularly critical for those who are in helping professions. For successful professional self-care, it's important for staff to first feel safe at work, to feel connected within their professional community, and to know that wellness is a shared priority of their institution, their supervisors, and their colleagues. A risk of discussion of professional self-care, particularly in isolation, is that if we don't sufficiently emphasize the important context of institutional and cultural prioritization of wellness, which is in many ways a precondition for professional self-care, we risk having professionals blame themselves for feeling challenged by their work, even when it is inherently challenging. And then we hold them responsible when they don't heal or support themselves. So we have to start first by giving institutional and organizational support, but professional self-care is also important. We need to create a culture where it's okay at times to be upset when upsetting things happen, and where everyone looks out for each other, normalizes asking for and accepting help, and models of willingness to accept this assistance. We have actually now had a couple situations where there have been major school crisis events, and what we have done is actually encourage them to have not only an employee assistance program, but actually to have what we call an internal EAP, where they take someone from the employee assistance program or hire a new mental health provider who works on site in the school just to support the adults. If you think about it in schools, mental health services for children is part of the services that the school provides, but they're not there to provide support to their staff. That's usually considered a benefit and is overseen by HR. And HR doesn't usually have that much expertise in dealing with crisis events or in mental health services. So we try and make sure that the adults in the systems also get the support. So it's critical that in your work, whatever way you provide support around suicide prevention or postvention, that you take care of yourself and your colleagues. 50% of adults overall know someone who has died of suicide, and I would suspect that percent is much higher for those attending this webinar. Usually people are drawn to the field because of personal experiences. So you're very likely to know someone who died by suicide or attempted suicide, and you may have attempted suicide yourself or considered it in the past. I went to one school that had a cluster of suicides in their middle school, in rural community, and 3 students in one grade level all died by suicide in the year. And they also were dealing with a large-scale natural disaster, and there was a lot of poverty, substance use in the community. It was really a very complicated situation, and they had almost no supports in the community. And one of the teachers asked to speak with me, and she said, this has really been hard for me. And she talked about the fact that this was her first teaching position. She had just graduated a couple months ago. This was her first time she had taught in a classroom. It's also the first time she actually moved out of her parents' home. And she had signed her first lease for her apartment. And she said that what was making it so difficult was that she had tried to kill herself when she was in high school, which was only a couple of years beforehand. And so she said, it's really hard for me to talk with these kids about this. And I'm a new teacher and I don't have the training for this. So I asked if she had talked to the principal about it. And she said, no, the principal just came to observe me in class and I didn't do a good job because I was so anxious. And I said, well, maybe you should talk with her. And she said, I can't. The first year you're on probation. And if I lose this job, I won't be able to afford my apartment and I won't be able to get another job. And she said, I cannot let her think that I'm in any way vulnerable. And so we talked about this, about how difficult that is for her, but you can imagine. So it's important that in the work that you do, you remain introspective about the impact of suffering of others is having on you and your colleagues. Exposure to the trauma and suffering of others can lead to what we call compassion fatigue. So compassion requires empathy. We have to be able to take the perspective of someone else, but compassion goes beyond empathy, and it includes wanting to help and or desiring to relieve the suffering of someone else. Compassion actually has Latin roots, which mean to bear or suffer together. That's the co part of compassion. And warnings about compassion fatigue come as a result of that because you bear or suffer together with the person. And they tend to imply that compassion is necessarily tiring or exhausting. Like you're born with a certain amount of compassion. If you care too deeply or about too many people, you're just going to run out and get burnout. But actually, compassionate approaches can be gratifying and they can bring meaning to the work that we do. So we are actually more proposing that you think about compassion satisfaction. So for this to be effective and for you to get compassion satisfaction, you have to have realistic objectives of the purpose of your interactions. For example, if you're working with people who are grieving or coping with any crisis, the goal is not to take away their distress, but rather to help them begin to learn how to cope with it. You also have to be aware of and have sufficient support to deal with the personal impact of the work. Compassion actually does require more emotional effort, but it's like physical exercise. You start an exercise regimen, it's really exhausting at first, but over time you build your capacity and it becomes sometimes really energizing. So you just have to realize that when you start this work, you're probably not going to be able to do as much compassionate care without it feeling overwhelming, but you grow into it. And so really those compassionate approaches can actually bring meaning to the work and decrease burnout. But you also have to have the skills and resources to provide meaningful assistance and feel empowered and supported to provide this help to others. Otherwise, you risk moral injury. And you also have to recognize that listening to the trauma narratives by empathic professionals can actually cause vicarious traumatization. And so you want to limit the amount that you do listen to this, unless you're a mental health professional doing trauma work. But if you're just somebody supporting a student, for example, you don't need to hear their whole trauma narrative to provide support. I'm just going to end with a couple resources. You can find further information and materials at the National Center's website, which is schoolcrisiscenter.org. One document we have, for example, are these guidelines for responding to death of a student or staff by suicide. It's about 4 pages long and has embedded links online so that if it says notify families, you can click on a sample of a notification letter, for example. We also do run the Coalition to Support Grieving Students. I'll end just by telling you about that and their free resources. So over a decade ago, the New York Life Foundation and our center convened a meeting of the 10 leading school professional organizations, School Superintendents Association, 3 principal and school administrator organizations, the 2 major teachers unions, the NEA and the AFT, and the major organizations for school counselors, nurses, psychologists, and social workers. And we created the Coalition to Support Grieving Students and developed free online material. But once we launched the website over a decade ago, others asked to join. And so we're now up to more than 150 professional organizations, including the American Academy of Pediatrics, National PTA, Boys and Girls Club. It's a long list. And you can find our resources on the website, grievingstudents.org. They're all free of charge. We have over 20 video-based modules. You can see there's kind of a banner, this gray banner at the top, and it's a drop-down menu and it has over 20 different options. Under crisis and special circumstances, you'll see one on suicide, for example. And then we also have other resources that we feature. The one that up there now is a guide to talk to children about community shootings in the news. And we have that in English and Spanish. And then actually there's a whole nother menu below that, just a little lower on the screen. And we have this booklet, After a Loved One Dies, which is for parents and other caregivers about talking to children after a death. It is now available in more than 10 languages, in 10 languages, I should say. And so you can order it in English or Spanish in hard copy, or you can download in PDF in the other 8 languages. And this booklet is not only free of charge, actually the shipping and handling is free as well. And then we have a tip card, what to say and what not to say to grieving students. And that is available in English and Spanish and also free, including the shipping. And we now have created 3 more types of tip cards. One of them is specifically what to say and what not to say to grieving students after a death by suicide. This just is QR code so that if you want to give us feedback, please let us know about this presentation. And then the last slide is just contact information that I'll show in a minute. But otherwise, we should open this up to questions.
Thank you, Dr. Schonfeld, for sharing all of your insight and your multitude of resources that we can certainly speak very highly of. We will entertain some questions in the chat. We have one so far asking what your thoughts are with the role of social media where suicide can't be used. And so individuals then use unalive to get around social media filters that might throttle or block videos talking about it.
Yeah, well, I think that children will find ways, just like adults, to be able to talk about what they wish to talk about. And so I think part of what we have to do is we should be filtering social media because a lot of things that are being posted are being posted in impulsive ways. And so we do want to make sure that we help protect people from impulsive acts, such as posting something around suicide. But I think we also have to have conversations with children so that they know how to filter what they see, and they also have the ability to bring some of this to the attention of adults. And so what we have found is that when you have open conversations with students, they will come forward and talk with you about their concerns about others. I remember once my daughter was home after she started college. And so it was like her first holiday break. And she came up to me and she said, Dad, I really need some advice. There, I mean, she was in a sorority, and she said, in the sorority, one of the girls broke up with her boyfriend, and the boyfriend is now posting on social media that she's going to kill herself, and he's really concerned about it. And she goes, I don't know what to do. Like, I've never met this girl. I don't, like, do I reach out to her and say, I hear you might be suicide? She said, I don't feel comfortable doing that, and I wouldn't even know how to contact her over the holiday break. So we had a discussion, and I said, who's your faculty supervisor? Do you have a faculty supervisor? And she said, yes. And I said, do you know how to reach her? And she said, I can do that. So she reached out to the faculty supervisor. The faculty supervisor, within an hour, said, we are aware of this. We have been talking to the student. We will keep her, safe. Thank you for your concern. So I think what happens if kids know they can talk to you about things, they will tell you about it. And so, yes, we should block them from posting things on social media that are inappropriate, but we shouldn't block them, and we should encourage talking with them about what's really important to them.
Thank you. How about a further comment on how to involve students and families in the memorial process after a suicide?
Okay, so this is actually a very complicated issue, but an important one. So thank you for asking. Commemoration memorialization is in general useful. It helps kids feel like they have some active role in thinking about what happened and how they feel about it, and trying to figure out how they wish to remember after a tragedy has occurred. The complication is you really don't want to glamorize suicide as a cause of death and suggest that the way you will be remembered if you feel disenfranchised and unseen is by killing yourself. So that's the challenge that we always have. So first off, I think it's useful to kind of understand in general what are the phases of commemoration and what is the goal. The goal of commemoration is to kind of remember what we lost and wish to preserve after a crisis, not remember how it happened. That is not the goal of commemoration. We don't commemorate deaths, we commemorate lives. That's why we celebrate Martin Luther King's birthday, not the day he was assassinated, because we're not trying to commemorate assassination, but we do want to remember what we lost. So there really are kind of three phases. The first phase is really to come together as a community to express your grief and to offer support to each other and receive support from your peers. That's like the candlelight vigils. And so that would be appropriate if there was a suicide. It's because you're not glamorizing, you're not doing something different, and you don't want to suggest that if you die by suicide, your life is devalued. And it is inappropriate to talk about it because then you're asking kids to grieve without support. The second phase is to really try and come to some understanding of what was lost with the person's death. And the third is more to make meaning of what had happened. And that's more where you emphasize not what you lost by the death, but what you had gained by the life. And that's what you really want to commemorate. But it takes a while to get to that. So one of the things we're seeing right now is this movement. I've gotten calls and emails, I would say 4 or 5 this in the past week or so, about the empty chair at graduation. And so to me, an empty chair does not commemorate the person. All it does is remind you that they've died and they aren't there. It is just talking about the whole in the class, not talking about what the person contributed. I remember talking to a mother who was using social media and public media and trying a campaign to get an empty chair at the school. In the school, it was against school policy. And I talked to her one weekend, like on a Sunday for about 45 minutes. And she said, I just want to understand why you don't think it is the right thing to do. And I said, well, I explained that we are concerned about, trying to bring attention to a death by suicide different than we would by any other death. And then graduations are actually times of celebration for those who have accomplished their educational goals. It isn't meant to be for commemoration memorialization. So although you can have posthumous degrees, you can have family members accept diplomas if the child has earned the diploma, or you can have names read or a moment of quiet reflection. But an empty chair does not actually help you remember the student. It just helps you remember the death. And I said, we've talked for 45 minutes and I've read about this. I don't know anything about your daughter other than she killed herself. Like I know nothing else about her. And this isn't a way to convey it. What you really want to do is to think about how you can commemorate her life. But that's not going to happen with an empty chair at graduation. So it's complicated for multiple reasons, and I know people have different opinions on it, but that's the way we approach it.
No, thank you. And one final question. A school that had a recent suicide of a high school student, and that so many of the students were in shock because there, quote unquote, were no signs. How do we answer the why question?
Yeah, so first off, recognize the fact that kids, just like adults, can ask rhetorical questions. They may
Yes.
ask you, why does something like this happen? And
Mm,
you may not know. And sometimes what you
right.
have to do is say, that is frightening, or it is very unsettling to recognize we don't always know why
Mhm.
something happens. But we can tell you what to do to keep yourself safer and to keep your friends safer. So I think that a
Yes.
lot of times people are just going to say, but I don't know. And sometimes you have to have them sit with that uncertainty. That's why it makes sense to talk about this, is because sometimes people do not see the signs. And
Mhm.
we'd love to, I remember going to one school, a high school, where a student was a very popular student. She was actually the mascot for the school. And she was at the basketball game dressed as the mascot, then went and stayed with a friend overnight. They weren't drinking, they weren't using drugs. It was a Catholic all-girls school, and I really don't think they were doing anything. And they stayed in the same bed, they slept in the same bed, and the other girl woke up and found her dead in the morning. The autopsy was negative. She never had any symptoms. It was always death of unknown cause. And kids were coming, signing up to meet with me about I didn't know. And they tried to figure out what we call it omen formation. You look back at something that's trivial and you assume that it was an omen and you failed to act on it. So one of the girls said to me, do you believe that you can tell the future? So I just said, why do you ask? And she said, well, this is going to sound odd, but every time I see a peer, they were juniors, I can see what college they're going to go to. And I said, so why you mention this? And she said, a couple of weeks before the girl died, I saw her and I didn't see a college, and I knew then she was going to die, and I didn't tell anyone. So I kind of went over that we look back at things that we could have predicted this because it's more uncomfortable to realize you can't always. And once she kind of understood the phenomenon, she said, so it wasn't my fault. And I go, no, it wasn't your fault. Like maybe she wouldn't have gotten into college. I know that sounds horrible in and of itself,
Mhm.
but could have been that she didn't get into college. She took a gap year. Like even at that time, it wouldn't have changed anything. People were also talking about, oh, she had a headache the day before. And I'm like, she had an autopsy and it was negative. Like a full exam, they couldn't find, she didn't have
Amazing.
anything they could have found. So sometimes it's just really hard to sit with the fact that we don't control everything that happens in our lives. And I think it's best that we teach kids how to deal with that rather than
Yeah.
try and layer on a reason that we know is not true or don't believe
Mhm.
it's actually true.
And on that note, I think that's an excellent way to end the presentation. Again, Dr. Schonfeld, thank you so much for sharing your insight experiences and for founding the National Center for School Crisis and Bereavement. It's an outstanding resource. Thank you so much.
Thank you.
So
It's
at this,
fantastic.
yeah. At this time, we'll be breaking for lunch. We ask that you promptly log back on again at 12:45 for your first afternoon session. The choices are in the email that you sent on the attached agenda, and you will simply click on the unique link for whichever workshop you would like to attend. Thank you so much. Enjoy.
As Paula just mentioned, this meeting will end. You will not return to this Zoom link this afternoon. In the agenda you received for the meeting, you should see a list of workshops with individual Zoom links for each workshop. Again, this Zoom link will not be active this afternoon. Please consult the agenda you received from Nancy Mundy with the agenda that has all of these Zoom links on it. I will also post a link to that agenda in the chat that you can reference and download. Thank you. Apologies, the link was security protected. It should be accessible for everybody now.